Hope you all relate to Holi and Bhang because this is something, you know, everybody in my family, head and my mother-in-law is the first one to feed everybody. She prepares it actually. And it was an
Oh my
amazing.
goodness. Captain Sandhya, भांग
हाँ
पी
जी
के
मैम.
नहीं बैठे हुए. And I'm sure we are going to have a lot of fun today.
नो नो नहीं नहीं, मेरे को क्लास अटेंड करना था इसलिए मैंने नहीं लिया. नहीं तो आज तो कोई किसी की पढ़ाई नहीं होती आज.
पर हवा में अगर भांग होती है तो भी you know.
Whole family, my whole family, 9 of them. They are all
You could have picked
off.
those colors, you know.
No, yeah. And my mom-in-law doing cheers with everybody. It is so embarrassing actually.
But that's so good, you know. That's the way everybody should enjoy. Why not? It's a legal intoxication.
Yes.
No, when it becomes religious, it's a legal thing. So nobody can object. So good, so good. So thank you all of you to have joined the last session of the day. But I think one of the most important topics that we're going to talk about. I think this is one topic which is usually not addressed in any of the meetings and conferences because we are still struggling with it, and that is disclosure of medical errors. And that's one of my favorite topics to talk, because I feel everybody can talk about so many other things, but this is one thing we really need to start talking, brainstorming, thinking, how should we really be addressing this, because this is becoming really a bone of contention for all of us, and we are all struggling, facing, but nobody is belling the cat. Nobody is wanting to talk about it, because I think personally, individually, in our own setups, we all happen to see this happening every day. But most of us are, trying to just cover it up and minimize talking about it, or it just remains with those few who are actually facing it. But we are not dealing it as one of the professional hazards, as one of the professional communication that we must learn. Tell me if there's any organization where errors haven't happened. None. But then how are we dealing with it? Nobody likes to talk about it. We just try to cover about it. So I think today's topic is going to go way beyond the scope of master trainer program. Had it been just a set of trainers, I would have just dealt it at a very superficial level, where I would have talked about how do you really go about introducing this topic to the participants. But I think all of you are already so intensely involved with hospital management that you really need to know the protocol of doing it. You need to know how do you really go about managing and handling it, because I'm sure you all must be already doing it at your level. But then with this program or a session in the background, I'm sure your way of handling it is going to change drastically. So without taking much time, let me first of all ask you a question. If you were in a flight which was in a near miss crash, and some passengers, including you, were slightly injured, what would you like to hear, from whom, and when? Please unmute and answer, or raise hand if you want to answer this. Should I repeat the statement? Okay. If you were in a flight which was in a near miss crash, and some passengers, including you, were slightly injured, what would you like to hear, from whom, and when? First of all, would you like to know what happened? Why did this? Yes, I think we all want to know. Suppose if nothing was shared with you, will you accept it as it is? You would still be talking about it. And you will be assuming something happened, but they're not sharing with us. They're not sharing with us. Okay, whom would you like to talk about among the team, among the crew?
Captain.
Because we hope and we think he's the one who is maneuvering. So he's the one who would know what exactly happened. And if he could explain what exactly happened, I mean, you would be kind of satisfied with? And when would you like to know?
Immediately is the first choice.
Yes. As soon as possible. Immediately.
Yeah.
Immediately.
Yeah.
So let me share my screen with you and take you to my slides and simultaneously have a discussion around it, and then we'll have a role play and a couple of other things to discuss about a very relevant topic. And that topic is, one second, okay, where we are, there we are. And the title of the topic that I've kept is When Things Go Wrong. I think this happens with all of us. We don't acknowledge probably. So as you said that you would like to hear it, definitely, and from the captain, so that you know exactly what happened and how everything was managed, and as soon as possible. Now take a look at these, some of the real life cases that you must have read in the newspaper or internet. I've changed the name of the patient, but he was admitted in one of the state-run trauma center in Indian capital. He met with an accident with head injury. He was mistaken for another patient who had broken leg. He underwent a surgery to repair a fracture that he had not sustained. Second case, two doctors were accused of failing to diagnose timely, resulting in delayed treatment and death of a 51-year-old physiotherapist, admitted with high blood pressure with ECG changes. She went into cardiac arrest and died. Again, a real life case that I'm sharing with you. I'm sure you must have read about it on internet or in news. Yet another incident, a 30-year-old woman underwent a wrong procedure after complaining of minor abdominal pain. The surgeon mistook the patient and made an arteriovenous shunt for dialysis. Medical errors. We may think they don't happen, but trust me, errors like wrong site surgery, wrong medication, wrong organ removal, wrong treatment, wrong patient are very common. Right under your nose, they're happening. If I go by the JCI report, 2013, medical errors are the third commonest cause of deaths in US. We haven't done any study in our country. I don't know if we did, where we will stand. You can tell me better because you are part and parcel of the industry. According to an estimate by Professor Ashish Shah from Harvard University, 5.2 million medical errors happen annually in India. And I think this is underestimation. There must be way beyond it. Most of the errors are around medication error and patient care. A lot around surgery and procedures. And 4% around infection. In 60 to 70% of these medical error cases, the cause is poor communication. Now, what do we understand by the term error? A medical error when we fail to complete an action as intended or use a wrong plan to achieve an aim is an error. It may or may not result in adverse outcome. A result that differs significantly from what was anticipated. Or an omission when something was left undone, neglect of duty. But if I go by the definition of error by patients, what they think, what is error? It's very broad. It does not only include medical errors or complications, it includes even some non-preventable events. For example, procedures and surgeries that have documented complications, possible complications. even that are defined as errors by patients. Even poor service of quality, poor quality of service is also considered an error. And of course, poor communication. According to the physician, the definition of error is very narrow. Only deviations from accepted standard of care. Rest everything is not an error according to the physicians. Now, what are their expectations of disclosure? Patients expect all errors that cause harm, even including near misses where no harm has actually happened. On the other side, physicians believe only errors that cause significant harm should be disclosed. And I'm sure you must be witnessing in your practice also. Question is, what do patients expect when the error happens? For example, we discussed about that plane crash case. You expected immediate update by the most significant or an important person of the team and come out with the facts. So similarly, patients also expect full disclosure of harmful errors. Statement that error occurred. A lot of time when we do not agree or accept that actually error happened, that actually makes them feel that they have not been given a fair treatment. They want to know what happened, implications to their health. So how is that error or complication is going to affect their health, why it happened, and then how will reoccurrence be prevented. They also want to know what preventive actions are we taking at our end so that the same mistake does not happen or the same error does not happen. And then they expect an apology. Somebody wants to say something?
Yeah,
please.
Ma'am, I think Reena is trying to log in. She's not able to log in. She has put a message.
Is it? Just 1 second.
Yeah.
But she's not there in the waiting room. Ask her to log in once again, please. Because I can't see her in the waiting room. Oh God. Have you messaged her?
Yeah, put it in the group.
Yeah, there she is. Yeah, I'll take her. Yeah, there she is. Yeah. So, an important thing in the end is that they expect an apology. Whereas studies suggest there's a huge disclosure gap. Although 90% of the doctors support the principle of disclosure, but only 30% of them actually do the disclosure or like to do the disclosure. But the question is how to disclose an error. What patients expect is that they should be given the facts in a truthful manner and compassionate. And you must have observed when physicians disclose the error, that's done more like a matter of fact manner. Very objectively, with minimal disclosure, and sometimes not even taking responsibility for the error. And when it comes to expressing emotions or responding to emotions, you must have seen a lot of us fail in that front. Now, coming to the role of apology. How many of you think apology works?
Yes, ma'am, it works at times. I mean, most of the times. I have experienced it.
How many times have you seen, if I may ask all others also to respond, how many times have you seen the doctors actually genuinely apologize?
Rarely.
Very rarely.
Yes, not every time.
Not
The
everybody.
hospital management actually apologizes, or the stakeholder who's identified by the hospital who's handling the problems, they
Mhm.
apologize.
Mhm.
Or, but it's not the doctor, but it's the medical head, medical superintendent. He lands up apologizing. Means the administrative staff, the people in administration who are responsible for well-being and welfare, they land up apologizing.
So just assume that after the near miss crash, you landed, you are at the airport, and somebody like random from the ground staff comes and apologizes in a very, very matter of fact manner. And in a very technical way, he says, okay, this was the altitude, this was the height, this was the speed. And then we missed this thing. And that's why we were about to, land up to crash. And thankfully we are safe. What would you prefer? Getting from him or from somebody who is actually primary person who is
Doer.
attending you? So if the apology or the explanation or discussion is held by somebody who was not involved in the care, you haven't built any rapport, you do not know each other, you do not know each other's behavior or the way of interaction, and you're not familiar, there is no trust, there is no relationship, there is no bonding. So it looks more like a formality just to explain and close.
The patients, madam, patients expect that I want to talk to the senior management. They may hear the apology from the doctor or nurse or whatever it is, but after some time they'll say, no, we want to talk to the higher authorities and we want apology from them. So that is how usually it goes as Dr.
Dr. Pai, I completely agree with you.
Yeah.
If why do they want to escalate? Why do they want to go to the higher authorities? Because they are not satisfied with what deal they have been given here, what treatment they have been given here.
Yeah.
I mean, if I do a mistake and if I apologize, why would you like to speak to my employer? Yes, if I'm not apologetic, if I'm not ready to agree that I've done a mistake or something has gone wrong, even if I haven't done it deliberately, something has gone wrong in your care, and you see that I'm not repenting or I'm not sorry for what has happened. So naturally, you would want to speak to my higher ups and complain to them that this is what your employee did and this is what is the employee's behavior. And yes, of course, we know people at higher positions are expected to be far more mature in handling. But the thing is, I think each one of us should know how do you really go about handling such situations. So when it comes to role of apology, patients expect the physician or the management or somebody to come forward and apologize. Whereas physicians feel that apology means legal liability. And as a result, they hesitate apologizing genuinely. Now, when to have the conversation? As you said, you want to know it as early as possible, immediately. Are you all able to see these slides clearly, or this is covering?
No,
We
ma'am,
can
it's
see.
clear, ma'am. It's clear.
Okay, thank you. Okay, so whereas, I mean, if you will try to speak to the physician, they may say, I don't know. A lot of time you must have heard whenever there's any mishap in the country and we contact a person or maybe a minister or somebody, usually what do they say? I still do not have all the details with me. Let me get the details, then I'll get back to you. So they would avoid giving any statement. So similarly, in this case also, I mean, we have seen, I'm talking on the basis of the studies that are showing that physician would like to have the conversation when he or she would have all the facts in hand. But emotions will not wait for that to happen. And by then you will actually have a reaction. Studies suggest that 2/3 of the errors are not reported. Even if disclosure happens, it never meets the patient's expectations. It's done more in a cursory manner. And then trainees often do not learn to disclose because we don't have any program where we actually train our doctors and nurses. How about disclosing an error? And as a result, everybody does it as the way they are comfortable doing. So I invite all of you to share if they have any, if they've experienced something like this, either you being a patient or patient's family member or a doctor yourself who has done it. And in case if you did it, how did you manage it? Or any experience with something like this. At least maybe one or two of you can share your experience without naming the doctor, without naming the hospital, because we are here to learn from that experience and not blame or call name for anybody. Would anybody like to share?
Yeah, I will share one story.
Sure. Sure.
So it's a big corporate hospital. Like,
Mm-hmm.
so the patient having the B negative blood group.
Mm-hmm.
There is a patient admitted in ward, and the staff nurse has got the O negative blood,
Mm-hmm.
and she administered it actually to the patient.
Mm-hmm.
It's actually a pediatric patient. Came for dengue fever, platelets was less than the. She administered actually the O negative blood. And finally, after the transfusion, she came to know that she transfused the O negative blood. So he quickly reported to the management, and the hospital has actually informed the patient parents. So they called to the counseling room, and they have informed that CTs happened, and luckily they didn't any reactions due to this O negative blood. So they handled it very well, and they have informed, and then they have taken that, okay, nothing has happened, but you have informed to us. So we are grateful, and thanks for informing us. So this was, as you have said, the same was followed. Like they called and they have a separate room. Even the treating doctor and the management, medical superintendent, all of them was in the same room, and they have explained it, and they documented that actually what has happened, what was conveyed to the parents, and what they're feeling and their feedback. Everything was documented in like as a report, case report.
So good. I think the whole protocol was followed.
Yeah.
The only difference is in this case, one is I think O negative blood is used for, because O negative is a universal donor, so probably it's used for such cases. And also, fortunately, we did not have any adverse.
Yes.
I think that probably worked in our favor.
Yeah,
but I still appreciate the nurse reporting. Like if she felt that I've done something wrong and it can harm the child, that thankfully she reported on time, and the management also took action and communicated with the family, at least informed them that this is what has happened. But usually, I mean, I've seen people covering up, but thank you for sharing your experience, Dr. Bala.
I was a part of that discussion, and I was the one minuting the minutes.
Oh, my goodness. Wonderful. So wonderful experience here. Excellent. Captain Sandhya, you wanted to share something?
Yes, ma'am. It's just recently happened in one of large hospitals and big luxury setup. My mom-in-law suffered a heart attack. It was an STEMI, and so she was in emergency. She was wheeled into a nearby big branded hospital, and she underwent emergency CAG followed by PTCA, and received 2 stents. And so it is already it's actually a 1 or 2 day procedure in our hospitals these days. So advanced and great. And so after the procedure, she was in the ICU for 1 day, and next day in the ward, and supposed to be moved out on discharge. So after the procedure, she was in the post-cath area, and after that, like almost 6 to 8, almost 9 hours, 8 to 9 hours later, there is something called a sheath removal. So, on the groin where they have an access. So all the medical friends understand these things very well. So that is one of the very technical procedures, but appears to be very simple. But one has to be very careful, because it is one of the major arteries which could actually heavily bleed, and there is a risk of bleeding, hematoma and everything. And it is one of our performance indicators also, that how we have dealt with the patient. And probably something went wrong there. And so that was late in the night when it was removed. My father-in-law chose to stay there. He was very restless. I had come home. It was so nothing, nobody came to know anything. But next day morning when I went, so I was happy to see her that she was okay, but she's saying, I'm feeling very weak and my legs are paining like anything. So I said, okay, fine. After the procedure, and it was such a major this thing, you have received 2 stents. So now I assumed, so I judged the situation. She got shifted to the room, and from there she got discharged. And all the blood pressure was on little on the lower side. Her heart rate was okay, but little marginally on the higher side. She was otherwise okay, and we brought her home. It was just 22 days. 22 days later, she tells me, because I got very busy, and then I went on my travel spree. 22 days later, she tells me that, बेटा, ये जो दाग है, ये दर्द बढ़ता जा रहा है इसका, और ये ठीक नहीं हो रहा है. I said, Ma, can I see? As she closed the room, and when she showed me, it was something I just fainted, because I'd never ever seen in my 26 years of career the way the hematoma was not in the groin. It has reached till knees.
Oh my God.
At the backside of the knee, popliteal fossa, and the entire thigh was gray, actually.
Flamed. Oh my God.
I just didn't look here and there. It was 8:39 in the night. I took her to the hospital, and thankfully I am a healthcare professional. I knew there will be cardiology, somebody on call. It's a tertiary setup. There will be DNB trainee also, somebody. I just called the cardiologist on call and ensured that he reports to the HOD, other things activated, and the remediation, the drainage, everything took place. It was so painful for that old lady. So everything settled now. And but the only thing is, till date, it's been now 3 months total for the incident. Things didn't go well. So Tuesday again she scheduled for a CAG. But till date, nobody has actually. It is one of our technical faults, skill related faults, where we fail to arrest and put the compression appropriately and attend to the patient. In spite of everybody came and saw me, like, now it's healthcare is very small. We all know each other. Doesn't matter, irrespective of the brand and the hospitals. Everybody came and saw, including the head of the hospital. But the only thing is, there was not a iota of remorse that what have we caused to our patient. I that is something which struck me, that at least there should be some sense of apology or this thing, but nothing. There's been nothing. Oh, ये hematoma है, इसको चलो drain करना अब जरूरी हो गया. It'll cause tissue necrosis, it's pain, blah blah blah, and everything. And it was so funny when we keep teaching our nurses. They were scoring my mother-in-law on pain scale. How much is your pain? Within a scale of 10. And that time I also realized how funny and how painful it is for the patient. But so this is one thing.
That's an indication how we do things mechanically without understanding.
Yes, exactly. So,
thank you so much, Captain Sandhya, for sharing your personal experience with us. And I think that really shows.
If you give me just 2 seconds. Yeah. Madam,
yes, sir.
If we get this
just 2 seconds. Yeah.
If
so
Dr. Pai, just let me complete.
Sorry.
Yeah. So I was saying, being healthcare professionals, if this is the treatment we are receiving, what about patients? I think that should really alarm us. What's the plight of patients? Thank you. Dr. Pai, please continue.
Yeah, I just want to add that I can quote at least 100 times I have apologized, 100 or even more in my 20 years career. our main job is to apologize. Medical superintendents, I say my job starts with apology for not giving the right medicine, not giving the, room, not the food had a small, spider in it. So many complaints. Now, after all this, I just understand one thing. It is important to have processes in place, systems in place. Unless we have these two things, it will again and again occur. We can, go on talking about the complaint part, but the real thing is have the proper system. And earlier, I think Madam you spoke about checklist, about checklist manifesto. Yeah. And I think those sort of things only, because it is a system failure always. Yes. We cannot always point finger at one person.
No, it
not is always
protocol.
The system, protocol and system.
That's what is required.
And all the time monitoring the system, whether it is right in place and monitoring.
I completely agree. Thank you so much for your input. And when we say I have my work starts with the apology, and if you are willingly, happily doing it, that shows that you understand the importance of apology. But it should not end here, and I'm sure it must not be ending at that point. You must be actually taking corrective action and a preventive action so that we don't have to apologize endlessly for the same mistake that my staff has done. So how do we really minimize the mistakes by making sure that we apply CAPA to the situation? That's very, very important. So thank you all of you to have shared your experience. And I think that's what was expected, that I wanted to see things from various point of view. And Dr. Bala showed from the hospital point of view, Captain Sandhya showed her personal experience, and then Dr. Pai shared that he's been doing it every day and how apology helps. I think he has really endorsed that part. Coming to the role play. So this is a situation, that case one where patient's name is changed here, was admitted yesterday under your care with multiple injuries after a car accident. He had a deep cut on the left arm and needed suturing. He was mistaken by your resident and the staff for another patient who had a broken leg and was put for surgery to repair a fracture that he had not sustained, and you have already operated on the patient. At least open the wound, thinking that this is where the fracture is. So I really want some of you to, anybody who would be willing to play the role of the doctor who would do this disclosure of error. Quickly. Anyone? See, the idea of even role play is so scary, although it's just all of us and we know it's just a role play. It's actually very difficult. It's very, very difficult. So Dr. Pai, you said you have been doing it very regularly. So I'm sure you will be able to give a good demo to help them see how it could have been done. Of course, we would appreciate the, the challenge that you're going to face, but then I think you can consider doing the, So Dr. Pai would be the doctor.
Can you show that slide?
I will show. I'll show once again. Definitely. I'll show once again. So I want somebody to play the role of the patient's family. We don't need a patient, but patient's family, at least two members who can even act a little aggressive or unhappy. Okay.
Not Reena, madam.
Reena is not well today.
And not Balamurugan. They have already bad.
No, sir. I won't.
They have punched me enough.
Okay.
Very sorry, that was unintentional.
Reena is not well today, otherwise she would.
They dashed me enough. Okay.
Okay, so I think Captain Sandhya and I think Dr. Anuradha have raised their hand. So, okay, you be the patient's sisters. Okay, Rakesh, I'll show you the slide once again, sir. And then I want all other observers to see the doctor's perspective and the family's perspective. And let me quickly show you the slide once again so that you can read the case for your benefit. Yeah, this is the case.
Madam, I am the doctor, no?
Okay. Yeah, you are the one who is now going to inform the family.
Who has done the surgery. Okay.
You have done the surgery, yes. You have operated the patient. So let me know when you have read the case and we can move further.
Okay.
Thank you. Okay, so I think all of us will have our video off so that we can see only 3 of them and they can comfortably perform.
Okay.
Yeah, you can start, please.
So, Dr. Anuradha and Captain Sandhya.
Yeah.
I'm Dr. Rajesh. I'm the orthopedic surgeon who operated on your brother. Can you please be seated and be comfortable? I know it's a difficult time for you, and you are very anxious to know what really happened and why the surgery happened.
What surgery,
So,
doctor? We were not informed there is any surgery.
Yeah, so that is the point I want to tell you.
But are
Madam,
you are talking about our brother? He is not scheduled for any surgery,
yeah,
sir.
I'm talking about Rakesh only. I just
Rakesh Tyagi, you are talking about Rakesh Tyagi or some
Rakesh
other
Tyagi.
Rakesh?
No, Rakesh Tyagi. Rakesh Tyagi.
So there
So
is no surgery is supposed to be there, sir.
he
What
had a
surgery?
cut in the left leg, which we thought we will do suturing in the theater. So cut in the hand, sorry, cut left hand. Yeah. So it was little bit, larger cut, and uh, so we thought we will do the suturing in the theater, and we took him to the theater. But we I want to just tell you that, due to little bit of oversight, we thought there was some fracture in the left leg also. And
Dr. Saab, what you thought about it, or how can you think that? How did you think?
Yeah.
We did not say about any fracture. Neither did the hospital told us any fracture.
Madam, I understand you will be a bit not very.
Sandhya, was there any fracture which I don't know about?
Oh no, doctor. That's why it's shocking. Who performed surgery? What happened?
And to whom you have done? To our brother you are talking? I don't understand. I don't understand all this.
Yeah, madam, see, nothing bad has happened. Patient is safe, and there is no problem with him. Only thing is the junior doctor who brought the patient to the theater told me that this patient had a probable fracture of the left leg also, and we had to just open and see whether there was a fracture.
Wait,
why?
But nothing,
doctor,
there's no
doctor,
harm. No harm has been done. Yeah.
That is not
you
the
have
point.
you have opened and his leg. I think you operated for the fracture, and you're saying there is no harm.
And he's saying by junior doctor informed him. He has not seen our patient. Sir,
Actually, madam, yeah, I know it is very embarrassing for me to inform to you, but I apologize very sincerely from my heart that such an incident occurred, and I have actually taken some action against that junior doctor who gave me a wrong information. Yeah.
I'm
Actually,
sorry.
We don't want to know that.
Sorry, it's not
Yes.
Dr.
Yes, sir. No, we are not
We are not going to take it.
Why
You mean to say a life doesn't matter to you? It's just a patient lying, and you're telling us that it's such a mistake that he mistook, and then the other patient my brother was open.
This is hospital. No,
Yeah,
I'm not going to leave
Madam,
it here.
I know it is a very unfortunate incident, but what I said is that,
sir, this is a mistake. This is an error. There is no unfortunate incident. This is just overlooking the patient. Nobody is caring here. Nobody is bothered about. We are here for some treatment. You are giving us more trouble. We are already troubled with the accident, and it is such a big issue in the life. And you're talking about you're doing wrong things, and you're not. It's not intentional. You are mentioning that it is. Is that going to help in any way? You have already operated something which is not there. How can anybody think? And how can this happen in this big hospital? How can this happen in this hospital?
Nobody comes to check. Nobody comes to even ask what is wrong with him. He's been waiting for 8 hours. And that's how once it was come only to ask the names and everything. And then finally wheeled in without telling us, without informing anything. And now you come and tell us that he's wrongly operated.
And you have not seen, sir, how have you operated?
I understand, madam. Actually, I was there at the theater, and then initially they told me there was a fracture, and
Sir,
I
that
did
is your
examine.
that is your problem, sir. That is your team. That is your doctor. For
We're not
us,
going to-
it is life of our brother is important. Only brother. We are not going to understand this
And
language.
I'm sure that everybody knows in the world how
That this hospital how is working.
and what happens to the patients in this, world famous brand.
Sir,
And
you
I'll
are
ensure that
responsible.
Madam, I understand your concern. It is, we are, and I am at loss of words to console you. But, but I guarantee that there's nothing wrong that has happened. It is a small few sutures that has come,
You
and
call it
he
small.
will recover during the same time. There is not going to be any extended stay or extended any infection because of anything, and his length of stay in the hospital will be the same. We will not be no extra charges and all will be coming. You don't have to worry anything, madam. He's safe.
It's not about the charges. It's not
We
about
are
the
ready
charges.
to pay.
The way the patients are being handled in this hospital. And you can't equate it with money.
And they are saying it is a small thing. They are saying it is a small thing. It will get healed, but cutting themselves, already the patient has got cuts and they are cutting at a place and then they are suturing there. So many already sutures are there. It is, how do you think, Dr. Saab, we are going to listen to this? Sorry to say, we are not listening to this.
Salute to your patients, Dr. Pai.
Can I request everyone to come in?
Madam, save me.
Dr. Pai.
राजेश सर कैसा रहा? अब रीना overshadow हो गई, right?
Madam came at the right time.
Dr. Anuradha, you overshadowed my acting.
I kept the door open to run away.
I'm sorry, Dr. Rajesh.
I salute your patience, Dr. Pai.
Yeah.
Can I request everybody to come in? Have your cameras on, at least those who can. I think Dr. Pinky is traveling and Reena is not well, so all others can be here. Yeah. So very quickly, I want to understand, first of all, from Dr. Pai.
Yeah.
How did you feel when you were doing it? Very honest. If it was a real life case.
It's a disaster, crisis like situation to go and tell a patient bystander that a wrong surgery has been done, and it's a very, very, I think, a high, intense situation, and very difficult to handle. We don't know how the bystanders will take it. How much apologetic you are, there's no excuse. No words can.
Yeah. Just 1 second, Dr. Anuradha, I'll come back to you.
Yeah.
So I think the one concept that we all should remember here is breaking this news of error or complication is not easy. Even if it's a documented complication, one of the possible complications, even communicating that is like that some error has happened or that's not the outcome that you were expecting. So one realization we all must have is whoever is in that situation, that's where there's a term called now second victim. The primary victim is the patient or the family who have been inflicted the injury or situation. But the person who is also handling the situation has to be given an empathic approach. That's where the concept of second victim, because that will change your perspective of how do you really support that person while you are also supporting the family and the patient, but you support that person. That's one thing. So what were the thoughts that were coming to your mind, Dr. Pai, if you may share, if it was a real life case?
It was nearly real life, like thanks to Captain Sandhya and Dr. Anuradha, they made it really, in a difficult, to answer.
Yeah.
I was taking all my experience to, choose the right words and not to, give them any sort of, callousness, to show any, show more concern all the time and make them feel safe that nothing bad has happened to the patient. Maybe in that initial aggressive moment, they may feel very angry against the doctors, but later when they go back and say, "Oh, nothing wrong has happened. Oh God, that is."
Exactly.
At least.
So you allowed that dabda that we have talked in the last class.
Yeah.
Remember? Dabda. Denial, aggression, bargaining, and then depression and acceptance. You could see it here. Initially, it was denial. They were aggressive. They were blaming you. They were fighting. But then slowly, after venting and ranting, they were calming down. They were coming down. So, but I mean, you acted very patient and you allowed that process to take place.
Yes.
You allowed that internal process to take place where they would become aggressive and they will rant and they will fight with you, but then slowly after venting out they will be calm and they'll be in that listening mood and they will understand your point of view and they'll also observe your behavior. So all through your behavior was exceptionally very calm and comforting and compassionate. So that I'm sure that must have put them in doubt that should we really fight with him, should we really blame him for what has happened, and he is not hasn't done it deliberately. I think that's very important message.
And each word is important.
Oh yes, each word is very important.
You should not say that, oh, he didn't die, nothing happened, he's safe. Like that, we should not say like that. We should say no harm has happened.
Very, I think you have pointed a very important thing, and I want to share with that incident with all of you. A young boy, met with an accident. It was a road traffic accident. He was going, to distribute his sister's wedding cards. This is a real case, one of the government hospitals I'm talking about. And on the way, he unfortunately met with an accident and he died on the spot. His body was brought to the hospital and they didn't have, the forensic department. So naturally, they had to call people from the other hospital. So the postmortem was postponed for the next day. The family was informed that you will get the body tomorrow after the postmortem. But family was definitely very apprehensive, especially because they were in that, mood for marriage and celebration, and then suddenly this thing happening is absolutely two different directions of emotions. So they went to the medical superintendent requesting, sir, get the more, either don't do the postmortem, or if it needs to be done, please do it today so that we can take the body home and we can cremate and then think, now what do we do with the marriage and all, because that's what was their thought process. Now imagine, what did the medical superintendent say? He said, मिट्टी है, चाहे आज ले जाओ चाहे कल ले जाओ. Did you all understand what he said? Anybody who didn't get? Taya, nahi samajh aaya? So he said it's a dead body like ashes. Whether you take it today or tomorrow, it doesn't make a difference. This was his response. And what do you think would have been the retaliation?
Terrible.
A person sitting at such an important position does not know how he should be handling such an intense and sensitive situation. And trust me, this is a very common thing you get to see when you meet even people in higher positions. We may assume that people who are in higher position really know how to communicate. But like Dr. Pai said, every word has to be very carefully chosen. It's better not to speak than speaking anything at random and then getting beaten up. He was bashed very badly. His hospital, furniture and everything was. So you really have to be careful. But thank you, Dr. Pai. I think you really demonstrated how we should be handling an aggressive, and this is not aggression. This is a usual way people would react. Anybody, if I would be there, if you would be there, you will lose your senses.
It's a normal reaction.
It's a normal reaction. I think let's call it like a normal reaction. Okay, now I want to ask Dr. Anuradha and Dr. Sandhya. What do you think Dr. Pai did effectively that you felt that as a patient's family you were okay with? If you can one by one say, Captain Sandhya, if you would like to speak first. Unmute your device, please.
Dr. Anuradha was going to talk.
Okay, anybody.
No problem. Yes. Continue, Sandhya.
I felt Dr. Pai, first and foremost thing, he was very patient. His voice modulation, his face, he had a face with all the grief and regret on his face. So that was the most important thing. The voice was so composed that he was genuinely apologetic. I couldn't help appreciating that, ma'am. So throughout, ma'am. And I was very rude. I knew that, ma'am. I was very rude, and still it did not shake him up, and he was like continue. And what I learned, I picked up as few learning points, ma'am. The appropriateness of the words, ma'am.
Yes.
And we see, he very rightly said after some time that he doesn't have to stay longer in the hospital. It is a small incision wound with similar size of wound with similar type of sutures, and he would go home in time. There is no risk of infection. So these are 2-3 things which are literally, I would say, very strong points. And rest I'll leave it.
One sentence Dr. Pai said that really struck with me. He said, I am at loss of words to counsel you, to console you. I think that was, saying that I want to express my grief and my sorrow and my sorry to you, but I don't know how. I'm actually experiencing goosebumps, Dr. Pai. You did it so well. It really struck me. I said, come down to an emotion level, yaar. We are human beings and emotions are so good to play with. Only thing is we don't have to fake. I always say, don't fake an apology. Patients can make out. But at least try to sense the seriousness of the situation from their perspective. If it had happened to me or my family members, what would I expect? Dr. Anuradha, what did you think Dr. Pai did effectively, and that really, was something that you really observed?
Ma'am, first of all, the body language was very comforting only. It was not aggressive. Ki, haan, theek hai, galti ho gaya hai, kya hai, all right. So that was not there. Then again, his choice of words were very, very smart, because it wouldn't make us feel anger. The way he was explaining that, okay, mistake has been done, but it is okay. It's not a big mistake. But that same thing as Captain Sandhya shared, the way he said about that, yes, okay, we have done it, but the small wound is there, sutures have been taken, and no extra stay, no extra. Then practical aspect of it also struck when he said no need to stay extra, no need to pay. So that also helped me to feel the calmness in myself and anger. Because same thing has happened in with one of my patients, and I was just a friend visiting. So the way Dr. Pai was speaking, it helped a lot, whereas I've heard in other language also. Though sharing with you frankly that we are not as rude as patients' relatives are on the screen, on virtual. They are really pura body language, this voice and sounds, pitch and tone is really high, but still this helped.
But you were quite aggressive. You were acting very aggressive, actually.
And I cut him off every time he would like to say, I would cut him off. So that also did not make him angry. That is a very big point.
And I think one more point to learn from this is that adds insult to the injuries when you ask them to pay for corrective procedure that we need to do or for the stay that the patient. A lot of hospitals do this. I think this is absolutely unfair. We have to really undo this very strongly. Why should the patient pay for something that the patient has not done? And we have so many other heads where we consider expenditure. This has to become part of an expenditure, or the discount that you need to give, or whatever way you want to consider it. But then I think this has to be really, very carefully thought about. Should we really ask the patient to pay for the overstay or for the corrective procedure, for the mistake that we have done? So I think we really need to ponder over it once we. Now I want the observers to share their thoughts. What do you think he did effectively? If you could write in the chat box, that will be really nice, because then we'll have more ideas. I mean, Dr. Anuradha and Dr. Captain Sandhya also can do. So what do you think he did effectively?
Dr. Indu, I think the calm and peaceful responses which he was giving timely, Dr. Pai, I think that made a difference.
Very true.
These situations we face every day, and he rightly said that, every week 1 or 2 places, instances happen where we are just apologizing at these positions.
Yeah.
And our positions are such. And you have to outsource, and so many 2,000 staff working under you, where something is going wrong, you will never come to know. But ultimately, whenever a complaint is there, you are at the forefront and you have to say sorry.
Yes.
So I think his response, his maturity was appropriate to the role, I think.
Absolutely. I completely agree with you, Dr. Pinky. Absolutely. I think that's why I chose him to do the role play, so that all of us can learn from his experience, that this is how you have to handle, a family who is aggrieved and who is aggressive and unhappy. So how you really, so I have clearly written that he appeared very calm. He listened to the family. He allowed the family to talk. Then he also seemed apologetic, not only apologizing, but as Dr. Sandhya said, the facial expressions also communicated, compassion and sorrow and sadness for what has happened with the family.
I think, and you rightly said, madam, that we should not try to fake emotions, because that comes through. That is easily is identifiable. So we have experienced earlier. So it is better to be totally humble and say sorry, and just sit quietly, just to wait for that response. I think that only
agree with you.
And I think the temperament, Dr. Pai's temperament is fit for that role.
So as I said, that he did not even retaliate, and he expressed his emotions by saying that I'm at loss of words to console you or counsel you. I think that really meant a lot. And then he also assured about the care, recovery, and expenditure. Again, that was kind of, a point where the family felt, okay, I don't have to now pay extra, because that's also one of the concerns at the back of the mind, which they are not able to vocalize because they don't want to talk about money at this moment. But definitely,
in fact, Dr. Indu, I was thinking that I was trying to look look for a person of such temperament has to be there in your team who can actually. So, I was when this was happening, this entire episode, my mind was racing as to which person in my team, can act like this or should function like this. Sometimes,
I will get a job. I will get a job.
That's what I said. I said, do I take it as a hidden invitation to Dr. Pai to join you?
No, madam, it is out of experience of
yes.
listening to so many complaints.
So Dr. Pai start taking this seriously as a training topic. Disclosing of medical errors and handling the situation.
Anyway, madam, Pinky madam, thank you for your invite. I will come as a trainer at least.
It is a very big strength, and we all administrators who are facing these situations, we understand this very well.
Yes,
it is not an easy task, sir. It is not an easy task. It comes with a lot of experience.
Very true. So Dr. Anup says he was listening to the bystander and was not provoked by their anger. Yes, I completely agree with you. Dr. Bala, you said listening carefully, apologized, understanding the relatives' feelings. Yes, very true. Okay, Dr. Saifuddin says Dr. Pai has been made of this character by God. Throughout the, I don't agree with this. Okay, maybe yes, his temperament is that, but all of us can learn this. These are all learned skill. Anybody can learn. Of course, I compliment him if he has this temperament as his way of life. But then Dr. Saifuddin, all of us can learn this. And he says he's a good doctor, no doubt. Wonderful. Throughout the program, we have seen him too calm and quiet approach. Yes, because maturity and, that is visible. Experience that is visible. I agree. Dr. Anuradha's facial expression is truly, I will eat you for your mistake. Perfect patient party, yes. Although we were not supposed to comment on the patient's party, but then Dr. Saifuddin has taken the liberty to comment on your expressions, Dr. Anuradha. Okay, Pooja says he was so empathic, and I think it was inborn in his nature, and expressions were showing he's deeply regretted, and tone of voice so sad for the thing which happened to aggrieved patient. I completely agree with you, and I think excellent observations all of you have given. So that shows, see, if all of us could read this, family also can read this. They will also be noticing your facial expressions, your body language, your tone of voice, your selection of words. And if we can work on these things, we have been talking about these 4 things. Look at your body language, look at your facial expressions, look at your tone of voice, look at your words. If you can manage these 4 things, you can manage any situation. You can manage any situation. So thank you, 3 of you, to have done a wonderful role play, and that gave a lot of food for thought to all of us. Okay, Reena, are you out again? Okay. So we have done this case, we have had this discussion around it. And if the family's concerns are addressed, I think they calm down ultimately. Okay, so when it comes to disclosing medical errors, it's not easy, let's understand, because it involves a lot of embarrassment. You don't feel good when you are seen by others to have done that mistake or to have done that error. You expect aggressive reactions, and there's always a risk of litigation, because depending upon the extent of harm, and therefore the focus is usually on covering the error. We might even comment adversely who covered the error, but honestly, anybody who will be in that position would think of that as a suitable alternative. Even very seasoned doctors find it very uncomfortable and distressing to communicate these medical errors. So what are the barriers to disclosure? What do you think are the barriers to disclosure? If I may ask you, what stops? Why not we come out with the disclosure easily?
And one is like fear of legal actions.
Legal action. So maybe if you take 30 seconds and write in the chat box, because then everybody will get a chance to think and answer this question, because it's an important question to answer. So one is legal action. I completely agree with Dr. Anup. What do others say? Yes, bad publicity, absolutely. Fear of losing reputation, wonderful, completely, because you have a respect and you don't want to lose that. Legal issues, damage to property, defaming of institute, absolutely agree. Yeah. Image issues with patient safety, absolutely, Sharmishta. Then feel embarrassed and guilty, yes, Dr. Radha, I agree. Dr. Leah says, fearful of how the patient would react and what actions they might take. Yes, very unpredictable. Very unpredictable. They may physically, manhandle you. They may, ruin your setup. They may go for a legal action. They may call police. They may call mob to attack you. So I completely agree with you. Captain Sandhya says fear, first is the emotion and helplessness of not being able to show or share this fear to anyone. Yes, I think sometimes we don't know like what we are experiencing and how do I really express to the other party. You may be feeling bad inside, but to say this is sometimes not very easy. It shows how non-competent doctor is and fear of losing rapport with others patient also. Yes, you will be called incompetent. You will be considered incompetent. Agree. Embarrassment to the doctor. Yes, Dr. Anup, I agree. Fear of consequences and peer pressure. Absolutely. I think you have actually, talked about almost all the points that I had, put in the presentation. Just to quickly have a look at it, what we could have missed. One is that sometimes we are skeptical of the benefits of disclosure. Kya karna hai? What is the point? Where is the need? Especially if the harm hasn't happened. Why to create confusion? And also some of us believe that disclosure is unnecessary. Some also think it will cause unnecessary distress to the patient and family, and especially in event when there is no harm or it's a near miss. So you think there's no need to tell the family that this error has happened. They will unnecessarily become, distressful. Then some of the errors patient cannot make out. So we think patient is unlikely to find out. So what is the point in telling? A lot of time, while doing a procedure, something happened and patient cannot open his stomach and see what has happened. You would hide it thinking that there's no need to tell because patient will not get to know. Then of course there's a fear of retribution from the patient, legal, and even retribution from the colleagues also. You fear that they might even talk ill about you. Then there's a fear of a legal action and financial judgment, fear of having the patient's emotions, like Dr. Leah said, that you don't know how the patient's family might react. And there's a belief that the disclosure is primarily a factual conversation and not a complex interpersonal conversation. So a lot of time the disclosure happens in a very matter-of-fact manner. And people do not handle emotions and address emotions, and that becomes detrimental to the outcome. Believe that the outcome is not related to action or action on the part of the person disclosing. So that means I'm not responsible for what has happened. So if that's an attitude, then again it becomes a barrier to disclosure. And then lack of training in error disclosure. I think that's one of the primary one, because people have not been trained how do you go about disclosing error. And this is something one can learn with practice and with proper training. Now, what are the benefits of disclosure? I think studies suggest that skillful conversation and follow-up will reduce the risk of litigation and aggression. And a study by Harvard says that only 3 to 5% of the patients who are injured will actually sue you. Most of the negligent cases do not sue. So the fear of suing is actually probably more of an assumption than a reality. So we need to really, see how many people actually would sue you if they get to know about what has happened. Usually they are satisfied with the explanation and apology and appropriate compensation of the damage that we have done to them. Now the question is, why do patients sue? Those who sue, they're basically not suing because of the negligence. It's usually because of the ineffective communication, because they have not been treated equal. There's lack of empathy, there's lack of compassion, care, regret, and a feeling that they have been mistreated. So that actually triggers them to suing you. And then there's also a perceived or actual withholding of essential information, which they are able to make out, and they feel bad about it, and they feel cheated and unequal in the role. Now, this is one study I want to share with you just to help you understand and appreciate the power of disclosure. Of course, not people. I know people are not open to the idea of disclosing, but then this study from University of Michigan in 2005 and 2001, they brought a couple of changes in the way they handled the, cases and how they, handled the situation. So in that, one second, give me a second. I need to. So 3 components were changed. The first one was, if a patient was harmed, they acknowledged it and compensated those patients quickly and fairly. That was one change. Second was, if they felt that there was no error, they would aggressively defend the case in the court. And the third was, if there was any adverse event, they studied how to avoid them in future. So this is what they did. These were the 3 areas that they focused their time, energy, and effort. And ultimately that brought down the annual litigation cost to them to almost like 1/3. Then even the average time to resolve the lawsuits or the claim for the lawsuits were reduced from 20 months to almost like 10 months, 50% it reduced. And the number of claims of the lawsuit also went down from 262 to 114. So that shows that if you are able to disclose and handle it properly, you can actually bring down the cost to the hospital. Although this might apparently appear a huge cost, but in the long run, actually, it really saves you a lot of effort and money. So I'm going to share guidelines for disclosure of error to you. It's based on the recommendation from the Canadian Patient Safety Institute and UK's National Patient Safety Agency, but we can develop our own protocol. This, I found it very useful and interesting, so I thought I'll share with you. So step 1 is preparation, where you actually do the self-check. You seek assistance from trusted colleagues. Then you review available medical facts, so that when you're going to break the news to the family, you should know exactly what happened and how it happened and how it was managed. So you need to have the medical facts ready with you. And also you need to prepare yourself, because you are going to experience a lot of emotional reaction from the patient family, and you will personally experience similar emotions within you. So you really need to be strong at handling both the emotions. When it comes to performing, begin by stating that there has been an error. Normally we talk about it later and we try to talk here and talk there. No, trying to, beat around the bush. Go ahead with very clear message that yes, there has been an error. Describe the course of events, how it happened. Use simple language, non-technical language, something that they can understand. Don't try to explain them in procedure. We were, blowing in the gas and this is what happened. And there was an incision and it was supposed to be 8 mm and the incision went on to 10. No, just give them the overview of what exactly happened. Use frequent pause so that to check whether they're understanding or they have anything to ask. In between, if they want to ask, allow them a chance to clarify in case they don't understand. Then state the nature of mistake, what has happened, the consequences and the corrective action. Like you saw in the role play, Dr. Pai said that this has happened, but fortunately there's no harm to the patient. Fortunately, that's not going to affect the patient's recovery. Fortunately, that's not going to affect patient's walk. And you will not have any additional, cost to pay. So if you're able to talk about this, they get an idea, okay, this is what has happened, how this is going to affect or not affect, or whatever corrective actions you have taken at your end. Apologize. We usually think apology something means that I have done a mistake. So expressing personal regret and apology actually greatly helps. So the word that I'm sorry has two meanings. When I say, I'm so sorry that this has happened to you. The second expression is of responsibility. I gave you the wrong dose. I'm truly sorry. The first one is always appropriate because whether you have done it by chance or by mistake, or you haven't done it, but this has happened to the patient. But the second one will be appropriate when actually an error has happened because of you. There's no harm even saying, I am sorry, I've done this. I'm really sorry. Then sometimes when we use these ways to apologize, they really fail miserably. If there was an error, then I would have definitely said sorry to you, but sorry, I don't think that was an error. That's part of the recovery. There was a mistake, but then I'm not responsible for what happened. It's a teamwork, and it can be anybody who has misdealt with it. The mistake certainly did not change the outcome. In any case, he was in stage 4 cancer, he would have died. Or sometimes these things happen, they are not done deliberately, and it happened with your case. So it was there in the, it's documented that this can happen. So such kind of apologies fail miserably, and we should actually never use this way of expressing apology. Step 4 is take responsibility. Use I statements. I feel sorry for you. I feel bad for you. I understand what you're feeling. Had I been in your position, even I would have felt the same. Do not blame or speculate. Don't blame them. Don't blame even your team. Sometimes we do this. Okay, I'm going to punish my junior. Usually we don't do that. Don't do that. Don't blame or speculate. And do not accept fault unnecessary. If you haven't gone wrong, don't say that, okay, it was my mistake to have done this, because then that means you are accepting for something that you have not done. Next is invite questions, because that's where you will get to know what are they thinking, are they accepting, are they okay with this, do they have something to ask. Don't hesitate and proactively elicit questions or concerns that they may have and address them appropriately. So they may ask you, will there be an additional cost? Will I have to pay for the surgery? Or will the patient be able to walk? Will the patient have any impact later on after the procedure? So you will have to actually be ready with the answers to explain about the consequences or whatever the implications are. Then after that, make a follow-up plan. Explain the next step to minimize the damage and talk about CAPA. So what corrective action you are going to take, or what preventive action you are going to take to prevent these kind of damages to other patients. Discuss how you are going to meet the needs of the patients and family. Plan for the next update. So they may ask you, how will we know how is the patient doing? So if you say, okay, I'll update you in 2 hours, or maybe I will call you to see the patient yourself. So that shows that we are not ending it here, but that's going to be an ongoing update. And then remain accessible. I think that's very important. A lot of time I've personally seen doctors who have operated, and in case if some complication has happened post-surgery, they would not come and meet the patient. They will ask their seniors to talk to the patient and the family. They just don't talk about what has happened, even if it's part of the, one of the complications, documented complication. So remaining accessible, available to answer their questions, to talk to them is very important. Step 4 is document. It's very important to document what all happened, rationale for your clinical decisions, what you did and why you did, and then clinical outcome and plan of care, how you are going to deal with it. Discussion with the patient and family, that should be documented, because that will save you tomorrow in the court of law, that how you have updated the family, informed the family, person whom you have done, or the relationship of those who were present with the patient, the questions posed by them and the answers that you gave them. If you can document all this, this is really, really going to save you. Step 8 is debriefing, which we normally do not care, but that's a great step to learn from what has happened. Very important is back to self-check. Now sit with yourself, reflect on what all happened and how you all managed. There is no harm discussing with your colleagues with whom you can share your concern. Check with them, how do they do it? What do they do in such situation, or what is the right way of handling this? And then reflect. Actually, reflections help us improve. So that's a very important step. So just to summarize these steps: prepare, state what happened, apology, take responsibility, invite questions, make follow-up plan, document, and debrief. At the institutional level, if you are at a administrative position, then it's very important to integrate disclosure, patient safety, and risk management activities. So you will have to proactively bring this in the culture, where you have a system where disclosure support system is available and people do not hesitate disclosing. So provide background disclosure education by training. Ensure disclosure coaching is done time to time, because it cannot be done just in theory, but you'll have to demonstrate, mock exercises, and also do it in real time. And then provide emotional support for the healthcare worker. The concept of second victim has to be addressed amicably. Create a culture of patient safety, learning from the mistakes, make sure that those errors do not repeat. Create a culture of even employee safety, because employees are also equal stakeholders. And then create a culture where people report errors promptly without the fear of repercussions or any consequences. Use performance improvement tools to track and enhance disclosure. That will help you in actually, creating a culture where people honestly come forward and share their concern. So this is in a nutshell about disclosure of medical errors. Yes, Dr. Anuradha.
I have two questions.
Please.
First is you have used the second point where we have to disclose what has happened. So there is a case which I want to tell. We had a 4-year-old boy. He had no NS when he was born, so he was in stage 3 of operation. First colostomy, then rectal preparation, NS prepared, and third we did colostomy closure. Patient was about to be discharged, but because we put intracat for just giving IV antibiotics, the cat gets blocked now and then, so we flush it before giving the antibiotic. So the flushing is usually done by simple water or sodium chloride solution. But the sister made a mistake. She gave potassium chloride and we lost the child immediately. And then I was working as an assistant surgeon there, but then the sir handled the case. I don't know how he did. I was not part of it. But in such case, what to disclose? First question. And second, when you said we have to invite questions, in such cases, what questions we are supposed to invite?
I think that's a very, very intelligent question that you have asked, and that's a very tricky situation if you ask me. If I talk about practically what people do, they would ensure their safety first and then think what they're going to disclose. If you ask me an ethical question, then you have to come out very honestly about it. Also, please remember, patient's family get to know that something has gone wrong in the care, because the child was fine and suddenly you gave an injection and the child collapsed. I mean, how much ever you try to hide it, they would know the fact. So if you really want to, avoid the legal action, then it's very important to tell them very honestly. But then it's an individual call always. Nobody can give you a dictum that this is how you should be handling it. But if you don't share the fact now, please know the consequences of not sharing. One, then they will definitely sue you, because they are going to, inquire what exactly happened. The child was fine and he was on the verge of being discharged and he was recovering well. So that means they're not fooled not to notice this, that injection was given and the patient died. Much before that, I think what is important here is to build rapport and that trust that we are responsible people and we work with care. For example, for all the time the family asked for intervention, if the nurse and the doctor on duty went to see the child and did whatever was required promptly, they'll have this faith. They, even if error has happened, they haven't done it deliberately and they are not callous in care. Usually where we fail is the initial working with the patient and the family. If you can ensure that even if you announce that this error has happened, they will still have this faith that yes, we have lost the child, but you haven't done it deliberately. But then it's a very tricky question to ask. Nobody can say, yes, you should do it or you should not do it. It depends. Sometimes I've seen your own staff going out and revealing the fact to the patient's family. And then they're aggrieved that you did not tell me the truth. Now I'll see you in the court and they'll also litigate. And this is now increasing actually. The trust is actually, going down. So definitely you can expect more cases in the time to come. But I think focus should be on being transparent and honest, following the standard treatment protocols. And then of course, building on relationship and trust of the patient. That's very, very important. That's very important. If anybody would like to, add to the points that I've said to Dr. Anuradha, from your experience, Dr. Pinky or Dr. Pai or Dr. Bala, Dr. Anu, Dr. Saifuddin, I'll be happy to have your comments. Captain Sandhya, from your experience. Let us
disclosing is okay, but what kind of questions we should follow up also in case
I'll come to that. We'll answer this question, but I want others to see what do they say. Dr. Pai, what do you say from your experience?
When a bad incident happens to a child, it is very more difficult to handle. And fully agree with you that we may have to counsel the parents, and but it is very challenging.
Very challenging.
We have always found it very challenging. But we have dealt with issues, similar issues where from instead of giving the milk through the Riles tube, it was given to the central line and the baby died. So we have dealt it, but it is very, very difficult, very challenging.
My goodness. So you can well imagine. So again, it's something, even if you're trying to hide, ultimately, if they get to know what are the consequences, that's something you have to keep an eye on. Dr. Pinky, anything from your side you wish to add? Okay, anybody else? Dr. Bala or Dr. Anu?
Yes, you have to take care of both the parties, parents as well as the person who did it mistake on that. So.
Okay, so your second question was, Dr. Anuradha?
If after disclosing that there has been a mistake and death has happened, what kind of support we can give by inviting questions? What kind of questions we should invite then in such cases?
See, questions is up to the family they would want to ask. So we can just guess what questions they may ask. They would like to know what happened, why it happened, what are you going to do, how are you going to punish the nurse who has done this, or how are we going to get compensated for it. So I think at this moment, they will be more in shock than actually having questions. You would expect less number of questions. Then actually they will be in shock, and you're being present there, counseling them and being supportive and helpful. That's very important. I can share 2 examples how we sometimes handle very insensitively. I think one case I've shared with you earlier also, but I'll share once again because this is the right point to talk about it. So this lady, she was known to me, and she was, she delivered a a baby boy in a small nursing home, and unfortunately it was a case of fetal death. I think the nurse on duty probably said, or the doctor who was there, somebody said that it's a dead baby. The mother immediately went into shock, and she went into probably amniotic fluid embolism, or she went into shock. And the lady was immediately moved to a bigger hospital. The dead body of the baby was still in the nursing home. So after say around 6 to 8 hours of gap, the hospital, these people from the nursing home, they called the patient's attendant, the father, the boy's father, that please come and collect the dead body. We have cats and rats around, so there's a risk to the body. So you can imagine, I mean, from one side we are discussing about how do you go about disclosing, the way actually in reality we are dealing with it. They would have really, bashed the doctor and damaged the whole hospital. Fortunately, I don't know, luckily I was there, and I kind of tried to talk to them and explain them that even if you do all this, how are we going to get back? And imagine the family lost both the mother and the child. That was probably the most unfortunate incident that I have seen. In another case, I was taking a session for pediatric group. So one of the very senior pediatrician who was head of the department in one of the government hospitals, he shared his experience that we had a baby, a boy who was, who needed intubation. So we called somebody from the ICU, because pediatric intubation is not easy. So we called somebody from the ICU to do it. So when he came, there were relatives around, and we knew that there are relatives, but we didn't want to shun them, okay, because we knew the condition is very critical, and they should know that the child is not going to survive, and we are doing our best to save the child. So we did not try to shun away the family. They were around. So this resident, when he came in, he immediately shouted at the family, saying that, what is this? Why are you all here? Are you going to treat the patient? Get out of this place. How can we work in your presence? And he made all the family members move out of that area. He intubated and went back, and after a while the child died. Next day the family came in to meet this pediatrician, and he said, who was that doctor? And he asked, why do you want to know? He said, we have lost the child. We knew we are going to lose the child, but we want to teach him a lesson. Is this the way to talk to the patient's family? So time and again we are getting this reminder. It is not the outcome. It is the journey. If you can ensure that you are with them in their journey, they don't care, because ultimately, even we all know life and death are in his hands. We all know this. If I have to die, I'll die immediately. Nobody will be able to do anything, even if you take me to the best of the hospital. But I think the lesson we need to learn from this is that we need to be more compassionate right from the beginning. So I always say, communicate for the rainy days. Build rapport for the rainy days. Build trust for the rainy days. You may not need it, and you may need it anytime. I personally saw a case, a young girl, 15, 16 years aged. She was, put for lumbar puncture. The resident who was doing lumbar puncture, I mean, he was a very responsible doctor, very well known for his good behavior with the patients and their family members. Unfortunately, during the procedure, we lost the patient. But can you believe the family did not blame the doctor? They did not fight with him. They did not, argue or say anything. They said, you haven't done it deliberately. I think these examples should teach us the importance and relevance of building rapport with the patients and their family members. Thank you, Dr. Anuradha, for asking a good question. Any other question you have? I hope I could answer your. Thank you. Any other question or comment anybody wants to make?
Ma'am, I'm coming from experience actually.
Yeah.
When such error happens, what is the right time when it should be revealed to the patient? Ma'am, this is one of the most important thing, because the delays actually makes the vulnerable hospital staff, being at the forefront and absorbing the brunt and the displeasure of the patient.
Yeah.
And that is the time when the situation deteriorates, and irrespective, like whatever amount of repair works you do, coming the hospital administration, the medical head, nursing head, everybody gathering around, it doesn't help. So what should be the right time? It's not possible immediately,
Yeah.
but the ambiguity is like it's not possible immediately. It should be with the facts and figures, but and by a serious, a responsible person. But like, when should it be there? Like, that is something.
See, I would say as early as possible. As early as possible, because any delay in communication is considered delay in care, because there's confusion, there is communication gap. So what will happen? A lot of assumptions will start popping up. And if there is no clarification, no explanation, no communication, then these assumptions will be considered as the facts. And the family will react on the basis of those assumptions. You're not talking to me because you are at fault. You're not informing me because you haven't done your job well. You are not letting me see the patient because you are mismanaging my patient. And if I come to you, I want to know how is my patient. I want to see my patient. I'm ready to show you the patient's condition is not okay. Give me a little time to settle him. You will be the first person whom I will take and show you. Even if I don't have all the facts, I can still go and at least talk to the family and communicate my feeling bad about it. We are doing our best. Give me a little time. Let me handle it. Let me see what I can do best for your patient. I think right now we need to work on the patient. I can come back to you and talk to you. Do you trust me? They are waiting outside. We are going in. We are going out. One person goes in. One person. Nobody makes eye contact. Nobody talks. Nobody puts a hand on the shoulder and says, "We are doing. Don't worry. Give me a little time. I'll come back to you." The whole team is working. We are all working on your patient. Give me a little time. I'll come back to you. I know you are very apprehensive. I mean, anybody in your place will be. I think that way we are very low on communication, less on communication, expression and handling emotions. I think we are just not. Whereas it is so easy, it breaks the ice immediately. Longer the gap, more the possibility of confusion, more the possibility of intervention by others. But yes, breaking of bad news or disclosure of error should be done to the primary caretaker. It should never be done in open. It should always be done one-on-one with only people who are directly involved in the patient care. But not like saying this, I don't want to talk to all of you, I just need 2 people. Rather, I would say, it's not possible for me to talk to all of you standing here. I think it will be good if 2 of you come in, especially those who are directly involved in the patient care. Segregate. Talk to them, sit with them, give them a glass of water, let them talk, let them shout, let them calm down. Because ultimately they will calm down. That's how human mind works. They will shout, become aggressive. And if you leave them in between and go away, then there's more possibility of mob attack and reaction and retaliation. Wait till they calm down. Wait till they are in that accepting mode. Wait to answer their questions. But then if they are okay, they're not going to carry any grudge against you and come back with the mob or, people to attack you. I know I've gone way beyond the topic, the scope of the program, Master Trainer program, but I felt this is how this topic has to be dealt, because all of you are directly handling this situation. So it's not just about training, it's about your own learning also.
Yes, ma'am.
So if there are no more questions, first I'm going to share the feedback for this question, for this particular session, and then we'll have presentation. So who all have not presented? I want to know. Leah, you have not presented. Dr. Saifuddin has not presented. Who all? Dr. Pai?
Yeah.
आपका भी रह गया था 3 लोग, डॉक्टर शर्मिष्ठा 4, और कौन रह गया? So still 4 people are left. So if I request all of you to cut down your presentation by 5 minutes and keep it to 10 minutes, then maybe we can have all 4 presentation today and end it. Because I want each one of us to present. And I want each one of us to go back with all these pedagogies because they are important, learning points. For example, I used experience sharing with you. I made you do role plays. So these are going to stay with you because you have seen this happening and me doing it. So I'll share the feedback form first, because let's close this. Okay, I've shared the feedback form. So all of you are requested to complete your feedback. So this session may go a little longer, but since it's the last session, then let's finish all the presentations. I hope the link is working.
No, ma'am, the link is not opening. I'm just going to try once again.
Okay, can I request someone to put in the chat box, or sorry, in the WhatsApp group?
Ma'am, it's opening in Chrome, ma'am. It's opening in Chrome.
Okay, thank you. So I've received 7 responses. Waiting for 4 more to complete. So meanwhile, I request all of you to be ready with your presentation. So I think Dr. Pai should go first because his presentation is still pending from the last session.
Okay, madam.
I know you were traveling last time and you could not.
Yeah, that's sorry for that.
No, that's okay. I understand. But I think all of you have attended this complete program with great dedication and sincerity. I'm really thankful to you to have taken it seriously. I think that's most important. And we all have learned a lot from each other. So 9 people have already responded, 2 more to go. I'm waiting for them to complete. Who all are still left? Please raise your hand. Dr. Pinky, you are still left.
Shall I put the link in the group? She can take it.
I think maybe, yeah, maybe she is
Right now.
having a challenge. Yeah. Okay, so Dr. Pai, meanwhile, you can.
Yeah.
Should I share this? Give you the screen sharing screen, right?
Madam, I don't have slides. I told you last time. No?
Okay. Okay.
So, dear friends, today I want to talk to you about patient communication. This is related to an experience that I had with a particular patient. I was the medical superintendent of a tertiary care hospital, and I received a letter from the Child Welfare Society of Kerala. So they were asking me that, can the tertiary care hospital admit and treat a child who is 14-year-old and who has some neurological problems and some addiction problems. So I was wondering why, Child Welfare Society has to intervene in this case, and it was a mystery. So anyway, since it is a request from a authority from government, we accepted the child, and and the child was brought from the medical college. And the history of the child was that he was in a private hospital in Cochin, where my hospital is also there, and he was there for more than 40 days, and the child won't talk much to anybody, and he will always keep his eyes closed. He won't eat anything, and such sort of abnormal behavior. But they had done a lot of tests, a battery of tests, which is required in this sort of neurological situation, MRI and then blood test, and there was nothing apparently wrong in any of the EEG and everything, except that in the urine testing, they found that there is some traces of, cannabis trace. It is only a trace. It is not confirmed. So this was the only reason why they suspected that somebody is giving, and this is only a 14-year-old child. We should know that somebody is giving some, this sort of banned substance to this child, and because of that, he is behaving abnormally. And there was a suspicion on the father and also one of father's friend, because the father always insists that he should be next to the child, and he will only give the food. So then they transferred to medical college. Again, the very lot of tests were done, and nothing. They could not find anything. That is how then they came to Amrita. Initially, our doctors were suspicious why we should take this case, but then I said, okay, we are tertiary care. We should give a try. And so sorry for that. And the patient was brought in, and I knew this issue of parent being always with the child, and I told the father that we'd admit him into the ICU and to see that whether there is any problem between the parent and the child. And parent readily agreed actually. We put him in the ICU for 2 weeks, and we did not find anything abnormal in parents' behavior. And then our pediatric neurology and pediatrics department, everybody had a meeting. We had a care conference, and we found that there was nothing, like a pathology to or a diagnosis on this child, except that it is something psychological. So we looked into the history of the child. The child had lost his mother at the age of 4 years or something, and he was being taken care of his grandmother. And then the grandmother died of COVID during the COVID. It is a COVID season, and she had got COVID, and his lungs became bad, and she passed away, unfortunately. And the child was in a state of great shock because she was the sole person whom he could interact. And then what happened is that father also became COVID positive. Father was the other person whom he could turn to, and father also could not be with the child for almost 2 weeks, 2 to 3 weeks. So that was the time when he developed these psychological symptoms. So this is the real history. So, but the problem was that we conveyed this to the father, that we don't suspect that there is any narcotic or
Dr. Pai, you're left with 3 minutes.
3 minutes, okay. So we talked to the father and told him that there is nothing, neurologically any problem for the child, but except that he is having some psychology and requires psychiatric intervention and lot of psychological intervention. But the father was refusing. He said, no, this is some problem. There is some neurological issue. So, by the way, he was a basketball coach of Kerala, and I knew one of my distant friend was also a very good basketball player and represented Kerala and India at some time. So I called him and asked him to talk to this coach, the father, child's father, and ask him to come and meet me personally. Till then, I did not speak. This all interaction was by the department team. So when I went through that route, he came to me, and then I explained to him. So there was some confidence and rapport built up with the parent, and I told him very nicely that our intention is only to save the child. We have no other intention. This is the tertiary care hospital, which you won't get better care than this anywhere else. That is why even government has recommended to come here. So you follow what doctor's advice gives to you. You don't try to intervene in whatever it is. It may be a psychological issue, it may be a bit of psychiatric issue, but if you counsel him, he'll become better. And I assure you that your child will walk from here. And that's also one problem. The child will not walk to the bathroom. Somebody has to hold him and take him to the bathroom. So this is all psychological. So with that counseling, the father agreed to accept the psychological treatment, and then because in Kerala, psychiatry and psychology is a taboo, big taboo. To accept that your child or anybody is psychiatric means it is society will just discard you and treat you very very badly. So that is the father's reason for not agreeing to psychiatric treatment. So what I want to convey from this was that good communication and deep history taking is very relevant in certain cases. And with that, if you build a rapport with the patient and bystander, they develop trust in you, and you can lead them to better clinical outcomes. So that is what.
So Dr. Pai shared a pedagogy of sharing a case study that you have personally worked on, or anecdote. that you have personally worked on. If you want to, in case if you want to demonstrate the importance of, first of all, staying non-judgmental to the patient and also communicating and building rapport with the patient. So something like this from your personal experience you can share, that would actually emphasize your point of view 100 times, because people will trust you more when you have your own personal experience to share. Thank you so much, Dr. Pai, for keeping it brief and short.
Yeah.
And okay, so who is the next one? Okay, Dr. Leah. So what is the time in your watch, if you could have a look?
7:28.
7:28?
Yes.
Okay, so you have 10 minutes time, and do you require the screen sharing rights?
Yes. Yes.
Okay, I've done it. Now you can share the screen. So please try to stick to 10 minutes slot that we have. Thank you.
Thank you. I hope you can see my screen.
Yes, we can see. Yeah.
Okay, so good evening, everyone. I'd like to introduce you to my topic, that is handling difficult audience. So let us make this, I don't have any activities planned, so let's make this really interactive. You can share your experiences also. So first, I'll be showing you a picture, that is, this shows the 5 types of difficult audience. I hope you can see the whole picture because I can't.
Yes,
and yeah, so if you look at this picture, you see 5 types of personalities, and all of them are named like the sniper, the snowman, the unwanted panelist, the black cloud, and the I can see the other one. I guess
clown.
the clown.
The clown.
Yeah.
The clown.
The clown. So maybe any of you can make a guess by looking at the character, like how this particular audience type would come out to be when you're giving a public presentation or giving any training session. Anyone?
It would be really very difficult because each one of them are will go in their own direction. They're strong personality. The sniper would always try to snub you. Snowman would probably say cool. The clown would actually would seek for something amusing or would pick up something. And yes, the unwanted panelist would certainly will have his view on everything what you would say.
Okay, nice. Thank you, Captain Sindhya. So what I'll do is I'll give you in detail about the characteristics of each audience type or each personality type, and maybe you can tell me, any of you can tell me how you would deal with each type of the personality, and I'll give you my own or whatever is there in the presentation. I'll let you know how to deal with them. Okay, so the first person is the clown. So the clown, they are very chatty and they pass on very lively comments. And what they like is they like to entertain the audience with the questions. And what they aim is that they try to derail you from the topic. They don't do it knowingly or unknowingly. They don't do it knowingly, sometimes unknowingly. So what do you how do you deal with such kind of audience where you have a clown type of personality and they are trying to make it all lively and trying to deviate you from the topic? How do you deal with such kind of personalities? Anyone?
You can make them part of your own training session or the session that you're taking. Just take them along and then let them follow you. Just make them follow you.
Then they will derail your program further. Every now and then they will interrupt you and they will give their funny statements, but they will not let you complete your session. So you got to be really careful.
Okay. Yeah. Okay. Any other points?
So Dr. Leah, how about telling them it was amazing. Your comments are so good. So can we take it after I finish my this particular topic? We will. I'll come back to you, and we will definitely discuss this with the whole class. But just give me some time, and I'll finish this, and then we will start talking about what you want to say.
Yes, yes,
Maybe.
great. So we'll look at how we can handle. So what you can do is they are very energetic, they are very lively. So use their energy very skillfully. Okay. So you can ask them questions and make sure that you are asking them specific questions so that they are in the topic. And also see that you're giving them plenty of eye contact. You are giving them attention because they're trying to seek attention, obviously. And keep a good atmosphere in your room and avoid being very serious. Otherwise, you will seem to be very arrogant or pompous. So you don't want that. And another thing is that allow the audience to enjoy the joke or the humor that they are trying to give. And again, see to it that you are bringing them back gently to your topic. So you don't do it arrogantly, but see to it that you are doing it gently. And the other personality is, we'll go to the sniper. Okay, so what a sniper would do is, he or she is very, what do I say? They listen to your presentation very keenly and they are looking for an opportunity to criticize. They will be looking for an opportunity to exhibit their expertise or their intelligence. So they'll be very carefully listening to whatever you're saying, to each and every word. So how do you think you are going to deal with such personalities?
I would say, Dr. Leah, you have to be very strong with your subject in such cases. So you are able to handle them.
Well aware, yes, and prepared, and ask their opinion.
We can have guidelines also to support our view in front of these snippers.
Okay.
We should be always confident in what we are presenting and never be deterred by any of the criticisms. That will be
yes, exactly. Yes. Okay, so let's look at how we will have to handle. Okay, remain confident. We shouldn't be fearful. Once they sense that we are feeling uncomfortable, they'll take advantage of us. So we should be confident that we are standing in the front of this audience for a reason. And another thing is that don't take it personal. That is us being humans, and when we are chased at our emotions and chased after our emotions, then we will be emotional. See to it that these snipes are not focused on us. Rather, see to it that it is directed back to the topic that is there in your hand. So don't let any of these bullets reach into you or your personality. Always deviate the bullet to the topic. And another thing is that, like we always say, listen to them, welcome their questions, and do not restrict them. Rather, you can, like how Dr. Indu had mentioned in her earlier sessions, she had shared her experience as well, like how she had dealt with a person who was pointing out her mistake. So either you can welcome, you can tell that, okay, thank you, sir, thank you for letting me know. Or if you have a clear and correct evidence, you can tell that firmly. Then another set of audience is snowman. This is the snowman is socially anxious and they are really introvert. They don't really try to participate in any of the activities, and they struggle to give eye contact. So, and another interesting fact is that they are really very involved in the topic and they know everything about whatever is happening in the session. It's not that, okay, this person is not talking, so he or she doesn't know anything. It's just that they are really very introvert and they don't want to give any input other than when they are prompted. How do you deal with such people?
We'll ask him to answer the questions directly.
Okay.
We'll indicate his name and directly point out on that.
Yes, great. Anyone else?
Involving them with a direct question or their opinion, taking their
Yes,
names
good.
to make them
Yeah.
participate.
Yes, ask them for we require your suggestion or inputs like that.
Yes, involving them. Yes,
Yeah.
exactly. So what we do is we shouldn't be put off by how quiet they are. You shouldn't assume that, okay, like I said, this person doesn't know anything or they don't want to get involved. It's just that they should be we should give them that feeling of being welcomed, and we should inculcate certain activities so that we are energizing them and we are warming them up for the further sessions. And next thing is that you can prompt them for insights. They are very intelligent group of audience from whom you can take insights about your topic, because they have always been listening, unlike the other set of audience who is trying to interrupt you, you know. So they are the audience who can give you very nice inputs. Another set is the black cloud. That is, they have this negative language, negative body language. They are always frowning and poor eye contact, and they have this can't do attitude. And they find sometimes they will be like, okay, I have seen it all before. And they might find your subject very boring or irrelevant. How do you deal with such kind of audience? No one? Okay, I don't want to take your time, so I'll go to how you can deal with them. What you can do is you can creatively engage them in the activities and show them that how you are different, and get them involved. And another thing is that be enthusiastic. By showing extra enthusiasm towards the subject, you are letting them know that this is not the subject that they have been introduced to. This is something different. Show them that you can change the way how they see for them. So make it a different one, sorry, not a difficult one, different experience, and be really supportive. Here, you have to be very patient and very supportive, and see to it that you're not defending them. You're not very aggressive, rather you are being supportive. And another is that another personality is unwanted panelist. Okay, the expert in the room who hasn't been asked to be present. They try to teach the audience, and the good news is that most of the audience, they don't like these kind of personalities. They find them very irritating, pushy, and distracting. And bad news is that sometimes, or most of the times, these kind of personalities would deviate us from the topic and also annoy the audience. So you are really very annoyed with their behavior. How do you approach them? How do you approach their behavior?
So Dr. Leah, a training session is going on, and the trainer has told about some particular topic, and maybe there are people who haven't understood. So we can put this kind of unwanted panelists to task and tell them to, brief about what has been said, and they can, actually teach the audience, and your purpose is solved, a revision is done. So maybe it can be done like that.
Yeah, great. Okay, let's see how we can deal with them. First is we set ground rules. Sorry, I by mistake did that. Okay, so first is we set ground rules, and then we set expectations. Like we can tell them that let's come to this room with an open mind and leave whatever knowledge or experience we have, and let's give everyone an equal chance to talk. Okay, and another thing is that whenever they are trying to interrupt, we can remind them about the ground rules, not aggressively, but calmly and firmly. Also, we can involve them in activities so that they are shown, or they are made aware that we are listening to them, and also that they are not kept away from the group, so that they feel involved. And another set of, we have other set like talkers. Talkers, they talk too often and for too long. We all know how to handle talkers, like how Dr. Indu had mentioned. We can assert that others must have a chance. And when they are taking a pause, thank them immediately and change the person, call another person. And it would be better if you would avoid making eye contact with this person. Next is electronic device enthusiast. You should be very careful when you're pointing out a person who is using phone, especially if you have in your presentations, if you need your audience to use the phone and you point out that, okay, this particular person is using the phone and he or she is using it for the purpose of the presentation and not for the personal use, so that you can't just point out from the audience. So in order to avoid yourself from doing such mistakes, you can set clear expectations that you can use the phone only for this purpose. And then other solid strategies, like either you shouldn't use the phone at all because my presentation doesn't require it. And another is even after pointing out they are using the phone, then you can just ignore and move on with the topic because you don't want to waste others' time. The takeaway is that you have to embrace the tough crowd. You have to empathize with them. You have to research about the audience that you are going to deal with, so that you will find a common ground and you will be able to work on that, build upon that common ground. And another thing is, like I mentioned earlier, do not take anything personally. You can deal with it in a very firm manner. Take a deep breath, remain calm, and try to deal with this with these snipers or any difficult audience patiently. Next is show that you understand. So no one likes to be told that they don't understand. So it's always essential that you are telling them or you are showing them that, okay, you understand that person and you're embracing it. And you can say that, tell me more, so that you are effectively and involving them in the discussion. And also they are feeling that, okay, I am part of this particular discussion. So yeah, that is it. Thank you. Thank you, everyone.
Very good presentation, Leah.
Thank you. Thank you, Dr. Pai.
Thank you, Leah, for an excellent presentation on how do you handle disruptive audience. I think that's one of the challenges you often experience and face. So it's more like revision for all of us, although we had a full session, but then you have done a good job by giving them names. So now you would remember, oh, he's a sniper, he's a snowman, he's a clown. So it will be easy for you to quickly choose how are you going to handle it. Thank you. Thank you.
So can tell us.
Yeah, please.
Any one of us, what personality you saw amongst the team?
That wouldn't be fair. I don't
would love to know. We would love to.
That's not the thing. I think it's a very mature group, and you all have voluntarily come for the program willingly, wanting to learn something new and interesting. So I don't think that we categorically fall into any particular this thing category, but at times we all have, sometimes, some of us would talk at length, some of us would not participate, but I don't think it will be fair to categorize anybody into any particular category. But then, of course, it should make us more mindful that whenever we are part of a discussion group, what will be the right way of interacting and participating. That's very important. Thank you, Leah. Thank you. Thank you.
Thank you, ma'am.
So moving on with the presentation, I think we have two more people, Dr. Saifuddin and Dr. or Sharmishta. So Sharmishta, you want to do this next presentation? Please unmute your device.
Yeah.
Yeah, go ahead. Yeah. So I've already given
Okay.
sharing rights. You can share. Yeah.
Good evening, friends.
Good evening.
Before starting my presentation, I would like to share one video. Please watch carefully. After that, we'll discuss on the presentation.
Sure.
दौरे मुखलिस में वो याद रखेगा हमेशा हालात ऐसे हैं लोगों को खुदा याद किसी की मुस्कुराहटों पे हो निसार किसी का दर्द मिल सके तो ले लो यार किसी के वास्ते हो तेरे दिल में प्यार जीना इसी का नाम है किसी की मुस्कुराहटों पे हो निसार किसी का दर्द मिल सके तो ले लो यार किसी के वास्ते हो तेरे दिल में प्यार जीना इसी का नाम है रिश्ता दिल से दिल के एतबार का जिंदा है हमी से नाम प्यार का रिश्ता दिल से दिल के एतबार का जिंदा है हमी से नाम प्यार का कि मर के भी किसी को याद आएंगे किसी के आंसुओं में मुस्कुराएंगे कहेगा भूल हर कली से बार बार जीना इसी का नाम है किसी की मुस्कुराहटों पे हो निसार किसी का दर्द मिल सके तो ले लो यार किसी के वास्ते हो तेरे दिल में प्यार जीना इसी का नाम है
So friends, will you please tell me what message I am trying to tell you?
There is no obstacle that cannot be won over.
Hello?
Teamwork.
Yeah.
Teamwork. And the teamwork always solves the problem.
Anyone else, please?
A leader can be anybody, like someone who is courageous enough to take the first step.
Right, right. Anything else from audience, please?
Yeah, Sharmishta ma'am, it can be like your attitude. What is your attitude towards the problem?
So, any more?
Everybody
topic, yeah, please.
Yeah,
please
yeah, everybody has their own, bundle of problems in life, and we should understand that behind their smile there is some what to say, a lot of problems hidden, a lot of tears are hidden in their smile. So, we should look holistically at all of them, and try to help others achieve their goals.
Right.
I don't know. I just felt.
Yeah. Any more, please?
There should be somebody to take command.
Yeah, true. Right. Good. Thank you everyone for watching this video carefully and giving your comments. So today, that topic was the ownership. As Pooja said, that somebody has to take command. So till we are not taking any decision, till we are not taking any ownership, problem will be there. So somebody has to take ownership, like leadership. So for that we need not require any qualification, not age, or not any high-fi degree or something else. But till you have this command or till your ownership, any problem you can manage easily. So that was the topic on ownership, but we will not discuss on the ownership or leadership. I have taken this topic as how you introducing your session on interesting way. So I have taken this video as my pedagogy. We'll discuss on how it is useful for the any other lecture or presentation. I'll share this. Okay, so topic was on introducing session on interesting way, using video as a pedagogy. So we'll discuss on the advantage of video. It is a great visual tool to back up what is in a textbook. If it is a extremely difficult or a topic that is not very interesting, video will create more engagement in the classroom. Don't have to read as much. It is good way to demonstrate something hard to put into word. Video give context to the word that are difficult to understand. Sometimes, it happens that based on the generation, everybody is not interested on the listening the lecture or showing the presentation, everything. So video can help in such a thing. Now we'll see what is the disadvantage of the video. It is time consuming to set up because everywhere it is not possible that we have a good setup for the presenting the video. If the video are not fun, engaging, student might not pay attention. Some educational video are just as dull as textbook. So you have to make sure you are using the right ones if you want to keep your students engaged. Like there is a young generation, and if you are using video which is not understandable or not with a good relevant topic, then you may not get attention from your student. If you are creating the video, you have to record and edit them, and this take plenty of time to get to the right format for your classroom. That is a technical problem. Sometimes it may occur. We'll see the do's of videos. Pre-plan what you want to communicate in the video. Whatever presentation or whatever message you are going to audience, first you have to pre-plan that whatever message you are going to communicate with, that should be linked with the video so people can understand very easily. Clarity of the subject or message, whatever message you are going to give, that shows in the video so people can catch your message easily. Know your audience, that I've already told you. Based on audience, you have to select the video. Make your videos mobile friendly. So if everybody is not present in the class, then they can watch this video even on mobile. Easy to understand with language. That is very much important. Notes of the video. Don't ignore the attention span of your student with a lengthy video. Like if you are showing video and you are not discussing, then it may be, your lecture would be not that much interactive. Do not use any religious video. That is very much important because the audience we may have with mixed group, maybe Hindu, maybe Muslim, Christian, everything. So you should not use any religious video. Video should be very clear with the cultural activity. Don't use video for any depth detail. The best approach to focus on a single topic and to keep the video as short as possible to cover the topic. Where we can use video, the application on the video. So video can be used not only for teaching, but also for studying and learning in and outside the classroom. Using as an advertisement tool for do's and don'ts. Video can be best method for explaining procedure, for example, medical or clinical procedure where demonstration is required. We usually in the hospital, all people are from the healthcare industry, so we are using the video to demonstrate the procedure, especially for the clinical procedure. And it is a best source of the online study. So that was the benefit of the using video as a pedagogy. Is there any question or any viewpoint from audience?
Thank you, Sharmishta, to have introduced us to the topic of video as a pedagogy. I think we often use it, and these tips of do's and don'ts and advantages and disadvantages will definitely help us in being careful in making the video useful and interesting and engaging the audience. And I think the video that you chose was very interesting, and everybody got engrossed in the music and the picture, although we have seen it so many times, but I think we all liked it. And the message, I think you said I mean, there are plenty of ways where you can use it, but one of them, that ownership, I think that was a good this thing. So thank you for using this as a pedagogy.
Thank you, ma'am.
So if we have no questions, can we move to the last presentation? And that's by Dr. Saifuddin.
Yes. So I think, Madam, share the screen.
Yeah. I've given the sharing rights.
Okay. As you're running out of time, so I think I should go to the presentation directly, without any activity. Throughout the session, what we have learned that Indu ma'am always asks, what is your opinion? What is your input? And then how will you handle this thing? These all the questions we have gone through the sessions. So I will present on these topics. So let me find out. Allow me time to get my screen on. Can you see the screen right now?
I think it's loading. Hopefully we should be able to see. It is saying you have started screen sharing, but we can just see a black screen. Yeah, now we can see it.
Wait a minute. Please allow me 1 minute.
Yeah. Should I share the presentation that you had shared with me, Dr. Saifuddin?
Yes, ma'am, it will be better. I am failing to get.
Give me a second, because you had WhatsApped me, you know?
Yeah.
Give me a second, I'll do that.
So by time I think we can do an activity that it's if I would like to request you all to take, if you have pen close to your hand, then a paper, And then
So
if
we are
you draw,
ready. If you stop sharing, Dr. Saifuddin. Okay, I'm sharing the screen now.
yeah, please, ma'am.
Give me a
So,
second. Yeah, we are there. Yeah.
okay. So I think let's stop the activity. Let's start with our presentation. So what I'll talk regarding the brainstorming. So you see in the image there is a brain and storm. So the storm is going throughout the brain. That is brainstorming. So what is brainstorming? Brainstorming is the team talk on a specific subject without interruption. That's what I have focused at the very beginning of my talk. That's Indu ma'am always asked, what is your input? What is your idea? Like that. That's the team talk. When everyone will talk on a specific subject. That's the main point, a specific subject without interruption. So what is the intent of brainstorming? To determine possible causes of a problem, to determine possible solutions of a problem, or to generate new ideas. Now come to the points that actually this is the most important tool and most used tool used by all of us, but most of us do it unintentionally. So how can we do it in more formal way? That is, number one is team formation. We have to make a team of 10 people or 5 people or people, but not more than 10. That's the very basic rules. If we take more than 10 people, then it will take lots of time. So number one. Number two is the participants of the team should be of mixed varieties. Multidisciplinary and diverse experiences will enrich the outcome. The second rules is next. Second rule is the set a time limit. So we have to set a time limit. It may be not more than 1 hour. More than 1 hour time will create monotonous. And the brainstorming session should start with a target problem, so that all participants will focus on that problem. They will not derail to the topics. And the fourth, that's the most important one. What we have experienced from Indo-ma'am practices, that's encourage every ideas, welcome every ideas, no judgment, just note, welcome and note down, welcome and note down. Whatever the ideas, whatever the level of oddness of that idea, encourage everything. That's the key points of brainstorming. Then the number 5 is aim for quantity. The more the quantity will automatically breeds to quality. So if a participants go for 4 to 5 ideas, take all those ideas and let all the participants participate to the discussion and take all the issues they give, and the participants can do, they can add on other ideas. That's mean that they will not state other ideas and will say but it should be no. They will take other ideas and will add and then they will continue. So these are the basic rules for a brainstorming session. It can be done in two ways, that is structured and unstructured. In case of structured, then we will pass one after one. In case of unstructured, the members they can be indiscriminately, they can talk. In the phases of brainstorming, there are 3 phases. That is, one is generation phase. That's what we have discussed. They take every ideas. Then the second one is, ma'am, go to the next phase. There's a generation phase. Keep talking, but keep focused. Always, there will be a facilitator in the brainstorming group. Whatever the structured and unstructured type, the facilitator will keep the participants focused to the same topics and will not interrupt. So that's the main issue, the count quantity, ignore quality. Then the second phase, that is the clarification phase and categorization. You see the OIRs here, the yellow color light, then the OIRs, there's a puzzle condition, make it a straight line. That is the clarification. If any idea give you ambiguous ideas, then clarify it. If they not understanding words or sentences, then clear it. That's the second time. Third thing is that categorize all those ideas. There will be duplication of ideas. One idea can be related to training, one idea can be related to motivation, one idea can be relevant to counseling. Then categorize all the ideas, what should be done in terms of activity and in terms of resources. Then the last point is this evaluation phase. In case of evaluation phase, we will reduce all, well, say for example, we have 10 ideas. Then we will go for each and every idea. Then we will analyze the reality. Can it be implemented? Can it be practical? In that way, we will reduce to the very practical sense. That's the main issue. Evaluation phase, we will reduce the ideas and analyze for implementation. And the last thing is that what we should do, capture everything, but what should we avoid? Evaluate anything. And what should we do? Encourage participation. And what we should not do? Force participation or sequence. And what we should do? Ask clarifying questions. That's the most important. What we do practice usually in our regular life, we go for judging question, but we should not do that in case of brainstorming. And the last slide is that I want to thank all of the faces in the screen and also the main heroine, I think Dr. Indu ma'am, who has put us together in that screen. Thank you. And thank you for the inconveniences that I faced to share the screen from my side.
Thank you. Thank you. So you have ended in a very dramatic way.
So sweet.
I was wondering, why is this picture? Why are we there in this slide? Okay. Thank you. Thank you, Dr. Saifuddin. I think you have introduced us to a very important topic of critical thinking, creative thinking, and that's brainstorming. And it can be used in bits and pieces in a training program when you want people to become serious and start looking for solutions. Even for small problems for which we do not have solutions around, we can use this technique. And it's an excellent way to make the group serious and responsible and accountable. And you can use it for training programs and for other management purposes also. Thank you, Dr. Saifuddin. Thank you.
Thank you, madam.
So can we clap for each other, because everybody has done a good job.
Yes.
Excellent job. Yeah, excellent job. Thank you. So with this, I think we come to the end of the program. Dr. Pinky, if you're there, if you could, we could have you there on the screen. Unless you're very tired and sleepy, because I know she's not there. Is she there?
She's not there. She's
not there. It's okay. It's all right. Reena is not well, so I think she doesn't want to have the camera on. But a quick feedback, just 5 minutes, and then we end it. Because it's the last time we are meeting for the program, not otherwise. I'm always available. You are always there. I know I can bank upon all of you, and you can bank upon me for anything related to training and programs. So quick feedback or takeaway from each one of you, starting from, okay, Captain Sandhya.
Ma'am, I don't know, that guilt is not leaving me actually. I have missed a couple of classes and I have not got time to look at those videos, which I feel are really important. But overall, it was a very thoughtful decision. I've actually thought over, do I really need to join this course or not? And there were many other things. And I don't regret actually while I've joined. There are many takeaways, and most importantly, 2-3 things which have started to give me good results from, immediately when I started after the sessions, is talking little slow, number one. And second is improving my listening skills on, trying to understand. These 2 things immediately started having their payoffs as well. So I've been benefited. But more importantly, I love being in this group, and that was the reason I missed it. And you are an amazing, I would say, anchor, teacher, and orator, mentor. And I just loved being enrolled in this session. Thank you, ma'am. Thank you very much.
Thank you so much. Thank you. God bless you. Thank you so much. So whom do you want to pass the baton? Whom do you want to?
I want to pass the baton to Dr. Anuradha.
Okay.
Yes. Thank you, Captain Sandhya. So yes, I was itching to talk. So thank you. First of all, thank you, Indu ma'am, for having me as a student of yours for this training program. I have thought and planned to come back in my medical field again in some way, but not as a doctor, because that is difficult for me to set up since we are rolling around with my husband's job. So this branch, I am very, very happy to think of being a trainer in. Because of you, I have got that confidence and the interest in the subject that this is an amazing thing and it has no end. As much as you read and learn, it is very important to participate, learn, and to give to people. So it's a beautiful subject and branch to work for. So that confidence, I have got it back where I was lacking. And I would personally say thank you to you and Dr. Samina, a friend of mine. I want to take her name here.
I know, I was about to say this, that I had promised Dr. Samina that, I mean, at the end of the session, you will find her confidence back and that zeal to start working again. And I think partially I have been able to successfully motivate you.
Yes, ma'am, a lot. And the team, I have met such amazing participants here, colleagues, that I would love to remain in touch with them. And I hope I am good at that. Means learning from Dr. Rajesh Pai at this means it's a big experience. Captain Sandhya, the zeal and courage. Pooja, such humble. Leah being so young. I feel like she's a daughter. My daughter is elder than her, ma'am. And Saifuddin Khalid, sir, so far away, but still participating with so much. Dr. Anup, that silent type, but intelligent. And Dr. Vala, always ready to help out. Sharmishta, Reena, full of energy. So all this I'm going to imbibe from each one of you and be in touch with you forever. And a lovely sessions, ma'am. Each session I have attended, so much to learn from you and so beautifully given. Thank you so much, ma'am.
Thank you so much, Dr. Anuradha, for such beautiful words. They're very encouraging, very supporting. And I hope that keeps me motivated and, you know, to do more and more in this subject. Yes, thank you so much. Thank you. So whom do you want to pass the baton?
I would like to pass it to Sharmishta because I have always, you know, got her later. Now this time I want to hear her first.
Sure.
Yeah, ma'am, I think they have used very good words for you. And I think in my dictionary, only word is left, and that is you are mother of clinical communication.
Thank you so much.
Yeah, the day I had talked with you on phone, so I was a bit curious. I don't know what was there in the clinical communication. In 10 days, I don't know what will they listen, what will they read, or what will they teach on the clinical communication. The way you have started and you have given the interactive session, it was really very nice. And the main thing, I have already put request to my higher authority for your continuous session with the other HODs. So soon again we are going to meet with you. So
Thank
I'm
you
not
so
going
much.
to see you very soon.
Thank you
but
so
it was
very much.
really very nice. The most important thing that all healthcare workers require clinical communication. You know, we have taken training a lot of on the communication, but the clinical communication, you know, what is the important role of the nurses, doctors, and the other paramedical workers? How many errors happen in the day-to-day in the India and out in the India? So the clinical communication is the only way it can help to reducing the error and the mishap with the patient. So I really enjoy your all and every session, and the group is really very good. I think all are very intelligent, very useful, very approachable. So it was really amazing to join this session with this all longer this. Thank you so much.
Sharmishta, I completely agree with you, and I will not take the credit of, for the success of the program completely to myself, but I would like to share the credit to all of you because all of you have been wonderful audience, very sincere, very participative. In spite of your positions in the system, you made it a point that you attended the program with complete, seriousness. I think that really impressed me very highly. Thank you so much, Sharmishta. Thank you. Yeah. So whom do you want to pass the baton?
Yeah, Pooja.
Thank you, Sharmishta ma'am. So, Indu ma'am, it's not the first time आप मेरे teacher रहे हैं and you are so down to earth. एंड मतलब मैंने ऑब्जर्व किया है कि कॉलेज में भी आप आते थे तो हम लोगों के साथ मेस में आप हमारे साथ खाना खाते थे, और मुझे सारी क्लासेस आज भी याद हैं जो आपने हमें साइकोलॉजी में पढ़ाई है मैम. एंड means I'm getting so emotional, and when I saw your photograph in that LinkedIn that you are giving such training, so I was so enthusiastic. मतलब मैंने टॉपिक भी नहीं देखा, मैंने बस आपको देखा. And I just enrolled in that program, or I'm really happy because I learned a lot, and it was just beyond my thinking, which I was thinking of, means what the kind of communication training which I have earlier attended. It was something beyond that, ma'am. And it is really practical. Practical means we can apply it, and even I have started applying some things. And even I have started my PhD research also on assertiveness training. I have just started. I have taken the review of literature also. और साथ ही साथ I just want to thank all here, because they all are experienced and I have learned a lot from everybody. Thank you Sandhya ma'am, thank you Anuradha ma'am, thank you Rajesh sir, thank you Reena ma'am, thank you Pinky ma'am, thank you Dr. Saifuddin, thank you Dr. Leah, thank you Dr. Bala, and thank you Dr. Anu. And I have learned a lot. Means I don't think that I have that stand to give some feedback to this program, because means I am very junior. And but yeah, I learned a lot, ma'am. And please stay in touch, all of you.
Sure.
Yeah, ma'am.
Thank you so much, Pooja, for such lovely words. I think you have really made my day by speaking so high about the program and for the group. And I think I really applaud the group's participation that has made the program really very interactive and enjoyable. Thank you, Pooja. So whom do you want to pass the baton?
Dr. Saifuddin.
Thank you, Dr. Pooja. Though I am not an Indian, but a participant of this group, the multi-diverse group, it's a very new topic to me, and it has opened a world to learn. So what I have learned from this program is that I have to learn more and more, and I have to practice more and more. That's the number 1 point. Number 2 point, the program actually started with an experience of handling difficult situation with Dr. Indoman. When regarding the position of my program fee, one of my counterpart from India, he deposited 1 lakh rupee to Indomam's account in spite of 10,000 rupee. That's a way I started learning before the program from Dr. Indomam. So number 3 is I think I should invite you all to my country to visit. Condition is that you have to carry your own transport cost from India to Bangladesh and Bangladesh to India. And during your stay in Bangladesh, you don't need to think anymore. I am here. And that is 1A, 3A. 3B is I will visit India. Then I think you will take care of me. 3C, all of us should visit Dubai, and Dr. Leah will take care of us.
Oh my goodness. Dr. Leah will immediately exit the group.
Breaking the bad news.
Breaking the bad.
Yes, please.
And number 4 and the last comment is, I practically do pray for all of you, so that may Allah bless you all, and may Allah increase your hayat, that is the living age in this world, and may Allah let us do good for our society, for the country, and for the world. Thank you all.
Thank you so much, Dr. Saifuddin. I don't know how we got connected on Facebook, and I never thought that we will actually be, interacting further. And friends, just to share with you, Dr. Saifuddin deposited 1 lakh rupees as a course fee. When I checked the, message that, okay, Saifuddin has made the payment, I counted the number of zeros. And I was surprised, is it 4 or 5? Is it 4 or 5? Then I asked my husband to see, what is this? Is it 4 or 5? And he said it is 5 digits, one lakh. I said, oh my goodness. I immediately messaged Dr. Saifuddin saying that, check how much have you paid. And he checked with his counterpart and we got to know that, oh, he had deposited 1 lakh rupee. So we had to reverse the entry, but do it in a very, proper manner so that he's not in problem, I'm not in problem. And that was a good learning for me also. And I think Dr. Saifuddin, you got this trust, I think, that, it's all about taking responsibility and being responsible to your actions. And
Yes,
as you said, the learning began from there, and it should continue. I'm thankful to you for the trust you had in me. I don't want to mention rupees 10,000 as the course fee, because that may be too much for somebody, too less for somebody. But the amount of time that all of you have invested, I think I really, really, appreciate, and humbly, thank you all for having that trust that I will make justice to your 20 hours. So I hope I have been able to make justice to those 20 hours.
So I should pass my baton to Dr. Anup, I think.
Sure. Thank you.
Yeah, thank you, sir. Yeah, I think first of all, why I took this course. So in my career, I found that one of my weaknesses was not bad communication, lack of communication. So I used to be quiet, and I wanted this course for some time. That was when I saw Dr. Rajesh Pai had shared, or like Dr. Indu's post in LinkedIn. Actually, me and Dr. Rajesh are friends in LinkedIn. So Rajesh has liked your post. And I knew Dr. Indu from the NEBH time, but we were not in, I think 2016 was when we did the course together. So then I immediately I messaged Dr. Indu, and that's how I came into the district. So I would and whatever time I had spent and the 10 sessions, I think it is really worth it. And thing is that I'm more confident now in speaking, especially with the people. I feel that I'm very confident, and I see that people also understand what I talk.
Wow, that's such a huge change. Thank you so much, Dr. Anup. I think the credit goes to the whole group that they have been able to, create that.
So I would like to thank Dr. Indu first, and again, other thing is that thank you again for selecting this wonderful group, because I was able to learn from each one of you, whether anyone, everyone was able to contribute. I would like to thank you all. Yeah, thank you very much.
Thank you so much.
We'll stay in touch. Yeah, thank you.
Definitely. Thank you. So whom do you want to pass the baton?
Dr. Bala?
Yeah, thank you, Dr. Anup. So it started from north and the ending, now it comes to south. So first of all, I'd like to thank Dr. Indu ma'am. First when I talked to you, like I said that 7 years back, I have attended the communication program, but this program is different from what I have learned from the previous communication program. This session is very good for about role plays and other pedagogies, brainstorming, and you could create a brainstorming about the critical thinking about the critical communications, how we'll do mistakes during the important stages. We could make out the points, what to do during these critical situations. Already I implemented and implementing the points we have taught during this session, like handling the difficult customers or patients, attenders, but still long way to go. And thank you for all your wonderful sessions. I also thank our participants, all the participants and wonderful participants to make the session very lively and very knowledgeable one. So with this note, happy Holi. We are ending with the flying colors, and my wishes to ma'am for the 4th program, as well as it is good should goes on to the other participants also for the wonderful program. And thank you, everyone.
Thank you so much, Dr. Bala, for your wishes and your appreciation. I really appreciate. Thank you. So whom do you want to pass the baton?
So I'll pass to Reena.
Thank you so much. So A wonderful session indeed. The whole program, the 10 sessions, it was amazing. And I was dying to say something. Dr. Saifuddin and Anuradha ma'am. Dr. Saifuddin, your true copy is in Ranchi. Okay, so I want to share the picture in the group. Please, everybody, see the picture, and it's a photocopy of Dr. Saifuddin. So this guy is a friend, colleague, Abhishek. Have a look. Isn't he a carbon copy? Almost. What do you say?
If the beard is grow longer enough, then I can replace.
Yes. Yeah, and each time I like get to meet Dr. Anuradha, you know, my friend, I have a friend, Dr. Anuradha. She's a an ophthalmologist, and she's in her late 30s, and her features, her face shape, complexion, her behavior, her nature is, I mean, you know, again, you both are copies. When she reaches your stage, she would be just a carbon copy of you. I don't have a picture, but I can't share that. But she's also so quiet, so nice. And, you know, being with her is a pleasure. So, the copies. And it was amazing with all of you. I feel really humbled and privileged to be a part of this team. Each one of you is so learned, such educated and experts in your field. Dr. Rajesh, Captain Sandhya, Dr. Bala, Dr. Anoop, Dr. Saifuddin, then Dr. Leah, Dr. Nuradha, Pooja ma'am, and Sharmishta ma'am. You all are amazing. Pinky ma'am. So, and above all, Dr. Indu. I always wanted to do extra in training about hospital because I wanted to be in the hospital sector. So I was browsing one fine day and I came across this IIHC. I was in two minds. Should I do? Should I not do? Because few months back I did the nursing communication course from KHO and it was not at all good. They don't share the materials properly. I was very upset. Then I thought what to do more, and I got in touch with you, and it was a matter of chance. I think it was all destined. I had to do the session, and I'm really grateful. Ma'am, please do not forget to share the videos. They're very important.
Yeah, yeah.
Okay.
Yeah, I remember.
So amazing session, and like each one of you were just amazing. Today, my daughter is very happy. Session khatam. Oh my God, 2 hours, 3 hours. You just forget me. And she's so happy. She came twice. Is it over? Is it over? I said, I'll just be back. Don't worry. So she's the happiest. But I'll
communication.
Yeah. We are holding you. Yeah. Thank you, Reena. Thank you so much for such a wonderful feedback. Whom do you want to pass the baton?
Thank you, Reena. Thank you so much.
Have we covered Dr. Leah?
No, Dr. Leah has not.
Okay, so I'll pass it on to Dr. Leah.
Okay. Thank you.
Okay, hello everyone. I don't know if I'm the youngest. It has been a very wonderful journey. To be honest, I do not want the session to end. And it has been a great journey and I have learned a lot from you. I still can't get enough of anything from you because you all are so much experienced and so humble. And other than communication, I have learned many other things also, and all thanks to Indu ma'am. I feel grateful that I got to be a student of yours, and thanks to all of you.
Thank you so much, Leah. Such a wonderful, simple appreciation, but I'm really humbled. Thank you for joining the program. And you know, it is just because of you that we stuck to Friday as the day for the program, because you said you can join only on Friday. That also from 8 to 9, I said, okay, we'll go by whatever suits you. And this is how I normally customize the program to meet the need of my participants. Thank you once again for joining.
Thank you.
So,
thank you.
Yeah. So anybody who is left?
Yes, Dr. Pai, we are ready.
Oh, I'm so sorry. I'm so sorry.
Last man standing between.
Most important person. Please, Dr. Pai.
So, madam, it was a privilege, to learn from you. You are, you are very the authority of, good communication, I think, in India, and well recognized now nationally. And your book got so much of publicity. Even your LinkedIn got so much of publicity. We are all honored to, be, learning from you. There are a lot of things which we knew, from our experience, how to handle, but, it all got crystallized with your concepts. So now we can confidently say, and share, with others how they should communicate properly. And, as a, module we can give to a lot of clinicians, and that will definitely help. Uh, I would second, I think, Dr. Anuradha, who, very nicely told about our, colleagues who are, actively participating, and everybody have been so nice. And but when you said you have to be the rude bystander, they did. Then only they were rude, like Captain Sandhya today, almost, took the aggressive Kali, Baba, and no, it should have been a holy, celebration. It was Kali Bhava, and I was really, bashed up. You saved me last, and said stop.
But you did an excellent.
Anyway,
So we keep coming across, and whenever I'll see Dr.
I have worked with Dr. Captain Sandhya in ABH assessments, so I know her earlier. So she won't go beyond a limit. I knew that. Anyway, as the pedagogies also were new terms for me, and there's a book, What They Don't Teach You in Harvard, like that, and I think your book can be termed as What They Don't Teach You in Medical Colleges and Nursing Colleges. Communication, basically. Nobody teaches. I've never heard anything of that sort. But I think there's plan by NMC to add this in the medical curriculum, which will be very useful for everyone. And as
especially the chapters on how do you converse with the different patients, and how do you handle difficult situations, and how do you handle different communications. These 2-3 chapters are very intense, and I think anybody and everybody will be benefited by reading.
It's very important, actually. Yeah. And so I think it's a very important topic, and it will prevent a lot of this sort of skirmishes and lot of conflict in the workspace, and reduce the stress of the doctors also, and the nurses. If you have good communication, good documentation, I think 90% of problems are solved. And as Saifuddin was saying about brainstorming, we were all doing a brainstorming in this session, and Madam, you allowed us to, always talk, and not, it was not didactic. In that way, I think your only 10% was slides and 90% was, on,
I completely
presentations. That was excellent.
Yeah.
And once again, thank you for, giving us opportunity to learn along with you, and thank you, the colleagues, everyone, for being such wonderful, team, and we will always remember each and every one of you, and we can all have, join in LinkedIn and follow Madam, what she's doing, whether she's in US or in India. And you can also suggest to us any programs which are there, which are good for us to take forward,
Sure.
in US.
Sure.
Training.
Definitely.
Thank you, Madam. Thank you so much.
Thank you so much, Dr. Pai. I think you have actually concluded the feedback in a very, very comprehensive manner, and you have given very right feedback for everybody, because everybody is a very coming from different background. They are all very learned, very experienced. So it was not like I'm tutoring somebody. It was like we were all working together and learning together. I think that's the whole purpose of the program. I don't assume it to be a teaching kind of a program where I am teaching. I'm no one to teach. Already people are experienced, knowledgeable. Only thing is I help you just organize your way of, functioning. And that was the whole idea. And I'm so happy and thankful to, to have had you all as participant for the program. I think honor was all mine. The privilege was all mine. And I thank you all for being there. And let's all stay in touch, and anything that you wish to ask about any program that you wish to conduct in your place. If you want me to talk to you about your format and how do you go about, I'm just a call away. Just leave a message and I'll call you back and we can work on it together. Your certificates will be sent to you through email very soon. And get a copy of it, get it printed, hold it like this. Send me a picture with your certificate. I'll be really happy to see you. Yes, you're holding the certificate. That will be a real, acknowledgement of the success of the program.
Sure.
Yeah. So hold your certificate. I'll make a collage of everybody and take a picture that everybody's holding the certificate. Yeah.
And should I show you this to everyone that I have got the book? So you can take it from Madam. Madam has sent it for me. You can take it.
I too got my copy.
Yes, I know. A lot of you have ordered your copies.
The thing is, 2 people in my office saw it and now it's circulating.
Oh, ask them to buy a set of books and keep it in the library. I think that
we already recommended that.
Oh, thank you.
I have got ordered for a few copies. I'll buy it from India. Next month I'll visit India. Then that time I'll buy a few copies.
Wonderful. Thank you
We
all.
are planning to have it in all our hospital libraries. We have
That's
libraries.
so good. Thank you so much. Thank you. So I'll request all of you to spread a word about the program if you really think it is worth spreading. If you think that more and more people should learn about communication and get benefited by the training, feel free to talk about it, put it on LinkedIn, on your social media, tag me. I'll be happy to share your post on my LinkedIn profile so that it gets spread across. And I'm looking for just positive, not fake feedback, but a real true feedback from all of you so that we can have more and more people on board. And if you feel like recommending somebody to attend the program, the next batch is starting from 26th March. So we are left with limited seats in case if you think somebody will really benefit, you can ask them to get in touch with me and we can enroll them for the program. So thank you. Yes, Dr. Saifuddin, you wish to say something?
Yeah, in case of virtual program, that is online program, it's consists of 10 sessions. But if you go for face-to-face session, then how much time you usually take?
So then we will actually, like for example, if I consider it 10 sessions, so in a day we cannot cover more than 4 topics.
Okay.
So it has to be around 3 days program.
3 days. Okay.
3 to 4 days program, because another thing is the pedagogies will have to be also integrated when you will be sitting and doing the group work and making presentation. So maybe another half day will be needed to allow you all to work on your pedagogies and make the presentation on day 3, or I think 3 to 4 days should be good enough. Okay. 3 to 4 days should be good enough, yeah. But number of participants cannot be more than 10 to maximum 15. I would say keep it 10 to 12. Because everybody should get a chance to, participate and answer and share their thoughts. If it is too large a group, then sometimes people who talk, who are more knowledgeable or experienced, they do most of the talking. Others miss their chance. So I don't want that to happen.
Okay. Thank you.
So thank you so much. I'll take a picture for all of us together with a smiling face. And I know you're all tired. I know. Sorry. Quick picture. Reena, you can't come, no? I know. Okay, so I'm taking a picture. Oh, wow. There she is. Captain Sandhya, I can't see you looking at this camera. Yes. Thank you. Thank you, all of you. Wish you best of luck. Have a nice
day.
Thank you.
Thank you.
Thank you, everyone, for being there.
All of you. Bye.
Bye, everyone.
Bye, everybody. And we keep in touch.
Yes.
Yes.
Bye.
Let's stay in touch. Thank you.
Bye.
Bye.